Hello, hello, welcome everyone. Even echo. We're just letting people into the room. I'm muted. Can you give it a test? No, still echo. Welcome, everyone. Yay. This is the January meeting of the Universal Health Plan Governance Board. Apologies for the delay. We were dealing with some tech issues in the room here, but we're ready to get started. We can get started with a roll call.
Yes, Helen Belanca,
Here.
Chun-Wei Chi,
Here.
Amy Fellows.
Here.
Michelle Glass.
Here.
Bruce Goldberg is on leave. Judy Richardson.
Here.
Cheryl Ramirez.
Here.
Mary Lou Henrich.
Here.
Mike Leahy.
Here.
Thank you, that's everyone.
Great. So quick agenda review for everyone today. After our executive director report, we're gonna spend some time regrounding ourselves in some information from earlier in our work. We're going to be reviewing some Oregon tax information and then a quick review of our principles. And then we will be launching into a detailed discussion about our revenue strategy. That's going to be the bulk of our meeting today, and there will be a vote on some of the elements of that strategy. After the break, we will do committee report outs, and there's one straw proposal for us to consider from plan design and expenditures regarding specialty payments. And then on the agenda, it says there's another vote from the transition committee. We were originally going to launch the transition committee today. And that was what that vote was about, but we've decided to delay that for a month, so that there's no vote on that today. Before getting to the public comment, we have been discussing the idea of starting a procedure where we have a consent agenda at each meeting, and I want to turn it over to Judy at this point to give us a little background information on that.
Thank you, Chair, and good morning, everyone. So a consent agenda groups together routine, non-controversial items such as meeting minutes and standard reports so they can be approved in just one vote. So this allows the board to spend more time on items that benefit the discussion, the benefit from discussion and public understanding. Any board member may request an item to be removed from the consent agenda for separate discussion, no explanation required. And generally speaking, we hope that those items in the consent agenda will be reviewed ahead of time and can be approved. So, Chair, if there are no requests, we'll proceed with a single motion to approve the consent agenda.
Okay, great. So today in the consent agenda, there are 3 items. One is our December meeting minutes. And then after that, we have a memo from our host agency, DCBS, about appropriate use of AI tools in our work. And then after that is a safety resource reminder from DCBS, just the basic agency safety strategies and phone numbers to call. So those are the three items in the consent agenda. As Judy said, if anybody wants any of those removed from the consent agenda to discuss separately, so you can speak up now about that. Otherwise, I'm looking for a motion to approve the consent agenda.
So moved.
Second.
Is there any discussion?
I spoke with Mimi and Isabel before. I had some minor mostly typos or little clarifications to the minutes that I'm gonna just give to Isabel. They were a little typo, pretty much.
Okay, nothing of substance.
Not
Okay.
really.
Great. Any other discussion? Okay, let's do a roll call vote.
Helen Belanca,
Yes.
Chun-Wei Chi.
Yes.
Amy Fellows. Yes. Michelle Glass,
Yes.
Bruce Goldberg is on leave, Judy Richardson.
Yes.
Bert Ramirez.
Yes.
Mary Lou Henrich.
Yes.
Mike Leahy.
Yes.
Thank you, that's everyone.
Okay, great. So now moving on to public comment. We have been discussing ways that we can simplify our public comment system a little bit. So there are going to be a couple of changes to how we do public comment. We want to make sure that we have enough time to hear from everyone who wants to provide public comment at our meetings. So we're going to be a little bit more clear about limiting the public comment at the beginning of the meeting to voting topics only. We will continue to reserve 10 minutes of time at the end of every meeting for oral comment. And we ask that each individual who's providing comment limit their comments to either the beginning or the end, but not both. And then that allows us to hear from as many people as possible. If you want to provide oral comment at the meeting in person, we ask that you please sign up by 8:50, 10 minutes before our meeting begins, so that we can have a total count of who would like to do that. And then online, it's 24 hours in advance, as it has always been. So thank you for understanding about that. This month, we only had one item of written public comment to the board. Tom Sincic and Valdez Bravo wrote an editorial for the Lund Report about the board's work, and Tom submitted it in its entirety for the board to review. If you haven't done so, I encourage you all to read that opinion piece. And then today we have 3 people signed up for public comment. I didn't see anybody sign up in the.
Mike, just because we've just started that, Mike actually, he signed up.
Oh, right.
Yeah,
So that's
we
what I was
have
wondering,
Mike
yes.
Huntington, yes.
Okay, great. So Mike Huntington and I have you down, Mike, as an in-person. So for the voting topics, we have a couple of elements of the revenue strategy that we'll be voting on, and then the specialty payment proposal. And so I think there are just 2 people for public comment on those topics, Mike Huntington and Alex Polikoff. Does anyone else want to speak on, did I miss anybody, I guess is what I'm saying, because this is a new process, and I just want to, the first time we do this, I want to make sure that we didn't inadvertently exclude someone. You don't have anyone else online? Okay. Okay, great. Then I'll turn it over to Mike Huntington, and you'll be speaking about the specialty payment proposal. Is that right?
Yes.
Okay, go ahead.
Thank you, Chair. My name is Michael Huntington, a retired radiation oncologist from Corvallis. I oppose today's proposal regarding specialist reimbursement as it is written and suggest amendments. I praise most of the proposal, but I'm concerned about value-based payment models. I'm in items 1 and 2, and the administrative burdens tied to complex pricing structures, item 4. Administrative simplification is the primary factor that you as a board have power to affect. It should precede new pricing strategies. Please avoid value-based payment models as we know them, particularly capitation and bundled payments. They shift risk onto providers, encourage avoidance of complex patients, and add compliance costs for risk adjustment and quality metrics. Over the past 20 years, capitation experiments in Hawaii have failed to integrate specialists effectively. But the collaborative care model has done so. Dr. Stephen Kimball, who you heard from before, who serves on the Hawaiian Health Authority, developed Hawaii's collaborative care model for psychiatry and mental health. He and his colleagues are delighted to work in the system. The collaborative care is funded through a direct plan contribution rather than billing codes, minimizing administrative expenses, improving access, and ensuring cost-effective specialist support for primary care. I believe you have written testimony. I got it in, I thought 72 hours ahead, evidently not. But I think we have other testimony from Dr. Campbell supporting what I just said. One Pair States is an organization of universal healthcare activists and leaders in 15 states. Last Tuesday, Dr. Hank Gorheis, a retired emergency room doctor and board member of the Maine Medical Association, spoke at a One Pair States meeting. At the end of his presentation, he praised Oregon for creating this board and the work that you do. He thinks Oregon will be the first to achieve universal health care. Freeing ourselves from value-based payments will help us prove him right. Thank you.
Thank you, Mike. I'm just double checking, if I've made an error there and there's another piece of written comment.
There is some additional public comment that was posted, I believe, on Wednesday with the submissions that were received 72 hours in advance. So there was more than one public comment this month.
Okay,
I couldn't access it, so.
apologies about that. Let me look.
Because I was out on Tuesday, it took a little bit longer.
Okay. Apologies,
Yeah.
Mike.
Yeah, Mike's is there.
Yeah, okay, apologies, Mike. I didn't know about that. Yeah, so please review those board members. There are two pieces of public comment there. Okay, great. Moving on now to Alex Polikoff, who I believe is online and interested in speaking about our votes on the finance and revenue plan.
Hi, can everybody hear me okay?
Yes.
Yes.
Great. Thanks for the opportunity to speak. Thanks to the board. So I'm going to talk about the voting topic coming up for the Finance and Revenue Committee, who have been doing great work. I really support most of what they're presenting. I want to address one thing, a couple issues though. One thing is the employee payroll tax credit. So the FNR is recommending a figure of 50% for that. They looked at 30 to 60% as a range they were looking at. My preferred figure would be 0, but since the range they looked at is 30 to 60, I urge the board to adopt a lower number for that. The reason why is because you can debate who actually pays the employer payroll tax, whether it's the employee or the employer, and who benefits versus who doesn't. But what's not in question is that any increase in that credit has to increase the base tax rate. And we are trying to, ideally for the public to accept it, it's got to be bubbler, broad-based low rate. So I think that's a mistake to have an increased EPT credit. Along those lines, you've gotten a lot of public comment about the tax not being progressive in the Finance and Revenue Committee. It is progressive by its nature because it's a marginal tax rate, but a lot of people won't understand that. You know, somebody earning 65K is going to say, why am I paying the same percentage rate as somebody who's making $1 million? So one suggestion, I mean, that's what people are going to look at and what's going to be used against you. So one suggestion would be to at least make it slightly, some progressivity in the actual rate, so that the revenue stream remains the same, but that it is an actual progressive tax. And I think that would be a little easier to sell. I was also going to make a quick comment on, there's some slides on ownership. I can't tell if that's going to be a voting topic or not. But I would just say, as far as that ownership piece, instead of making something, simplify it, instead of making something like some minimum contribution, just adjust by using your phase-in threshold as far as the personal income tax rate. Don't complicate things. You're already making adjustments in the background, and do it that way. Thanks for your time. Sorry to go over.
Okay, Thanks, Alex. Okay, our next agenda item will be our executive director report. I'll turn it over to Mimi.
All right, good morning, everyone. This is Dr. Mimi McDonald, I'm the Executive Director of the Universal Health Plan Governance Board. So providing some updates, if you want to advance the slide one. So I just start off, it's the beginning of the year with a little safety reminder. So you'll find in the packet a labor and industries building. That's a building that we're in. Some quick facts about the labor and industries building, and also some a number that people might want to program into their phone. This because as we know, tensions are high. They may become higher as the work moves along. So thinking about it's really important for everyone's individual safety that they do feel safe. If they have any concerns, please come to me or to the staff. And then we can also work with our DCBS staff. So thanks so much for that. Next, for any interested board members or the public, there are a couple public meeting law courses. If you take it at once, you may or may not want to take it again. We put the link in there. I think that the January meeting is passed, but there are still signups for the February meeting in case people want to remember exactly. It's a great, it would be a great refresher and actually have signed up. Next, moving on, our website, which we definitely appreciate, is getting a little bit clunky and a little bit full. Patty Wentz, our consultant, along with Isabel, our executive assistant, are working with the DCBS team on updating the website. I would say that it is important for people to have level expectations. It's not going to be a complete refresh just because of the framework that we have set up, but definitely reordering of the content to make it more visible. We had a recommendation that that now that the board has adopted a mission statement, that be prominently displayed, which makes a lot of sense. So just wanted people to know that that work is starting here this January. And so I'm really trying to make it more searchable when you're looking for specific things. People do have it, this for the general public or our board members or committee members, please shoot me an email if you have thoughts about it, for sure. Next, not sure how aware people are that DCBS, the agency that we're hosted, is temporarily going to be moved from this building. It was initially slated for the spring. We're actually going to go, I'm looking across the way into the finance building, but it looks more like the move will happen in August. So we will, of course, keep everyone posted, meaning that the physical meeting space will change a little bit. Next, moving on, I did include a couple things about AI utilization. One, which is a general DCBS policy, and then another one actually it is germane and it does pertain to people who sit on boards and committees. So if you have a chance to take a look at it, I found it very helpful. Next, I want to talk about our committee work. So as people have mentioned various times, committees are working incredibly hard. The timeline at this juncture is that 3 of the committees, so finance and revenue, operations, and plan design and expenditure, will have wrapped up all or the majority of their work. Their final meeting will be held in March. Now, things that are, if they were in, actually all the work plan items will have been taken care of. There will be a lot of refinement of the work over the following months that the board is going to be taking care of. Other things to know, the Community Engagement and Communications Committee, which has a meeting in January, and then they will actually be starting back up in the spring. So they will be continuing on, CECC will be continuing on, and there will be a transition committee. So the transition committee is, and we'll talk about this more later, but that will be starting in March, very specifically to work on the transition plan. So we'll go into more details, but I just want to be clear about what's happening with the committees. And then lastly, we're talking about board member outreach or other outreach. So I personally am going to speak tomorrow virtually at the One Payer States meeting. I'm really excited about that. And then there's going to be an in-person town hall with that same organization in March. And some of our committee members at the time, I think Tony Germain is also going to be there. And then POP stands for Protect Oregon's Progress, which is in Wasco County, which happens to be where Dr. Richardson and I live. And they've invited us to speak about the Universal Health Plan Governance Board. So we'll be there in person on February 24th. So that was a lot. Any questions?
Not a
Yes.
question, but I just want to add, I joined the website meeting and I know that there have been people giving feedback about the calendar being really wonky when you're trying to find things. And I shared my screen and showed the DCBS stuff, so hopefully
Oh, thank
They
you.
will
Thank
be
you. I didn't really
getting
think
that worked on.
Yeah, thank you so much. All right, moving on. Next slide, please. Okay, so we're just gonna talk briefly, I guess I'm gonna do my slide two here. So wanted just a regular update on our budget. There's a couple things that I would like to call out. So this is our 2025-2027 budget. Personal services hasn't changed. That amount is the same. What you may or may not notice under services and supplies, where it has actual and planned, if you look back at last month, that number was smaller. There's an asterisk by it because we are increasing some of our current consultant groups not to exceed values, and I'll go over that in the next slide. So that's why you end up with that number being slightly higher. However, not to worry, we still come in well under budget, even with the additions to those consultant groups. So with a remainder of $80,500-ish at this point, and we'll keep updating people. And then on to the next slide. So I was talking about those consultant groups. So one, don't panic. Sorry, I put things in red. I'm going to jump to that first. So Milliman, we have paid them the amount. They are still working on their deliverables. They will continue to support us until their deliverables are complete, which probably they'll be done around the end of March or so. So even though it says 0, they have not stopped working for us. Our consultant group, Echo Northwest, there you'll see an asterisk by their budget. Their budget is going to be, their not to exceed is going to be increased by 25%, which is roughly $60,000. So although currently the balance says 31, it is closer to 91,000 once we get the groups worked out. And the same with Wentz Jackson, there's another asterisk there. We're working on that, and that not to exceed is also going to be increased by 25%, bringing up that by $6,000 more for the total. So again, still in good shape. Yes, please.
Did you mention, at least to me, that Echo Northwest is going to be staying on beyond March 31st? I thought.
I think I mentioned it the last one, but if I didn't, they are.
Okay,
So
I was
everyone,
thinking.
phew,
Yeah.
hooray. Yeah, you'll notice that contract end date actually says 2027. We don't anticipate they'll be here that
26.
long.
Oh, duh.
That's
Okay, I
okay.
was thinking that said 26, like, no.
I know, otherwise we're leaving.
Yeah,
No,
okay, all right.
they are committed to working with us, for which we are incredibly
you.
grateful. So any questions about any of those budget items?
Oh, Mary Lou here. Can you say again about Echo Northwest that are we increasing, did you say we're increasing their?
They're not, so their not to exceed was 236,800. And so
Yeah.
that's going to be increased by 25%. I just didn't want to put it in the budget because it hasn't happened yet. So that's adding an additional $59,600 to their NTE.
So that they will be continuing
Yes.
to do their stuff with us.
Correct.
Okay. And I did talk to you about my panic about the Milliman.
Sorry about that. My bad.
What on the previous slide are special payments?
Oh, special payments, it actually will end, this is a little bit of a bookkeeping thing. That actual and planned special payments are going to be where the mileage reimbursement for the board is going to live. So I'll give you a little bit more
Okay, it's-
detailed.
I can talk later about
Yeah.
that, but I just was kind of confused because my major issue is not looking at detail of this, but it's looking at, how are we projecting that we're gonna come out the end of this biennium, not doing what happened at the last
Right.
end of the last biennium, which was leaving general fund on the table and using it and getting it
Absolutely.
slotted for the things that we really need.
Yep.
And we haven't really talked about what else the board has said, you know, we need X, Y, or Z. Maybe you have and the chairs. But anyway, I just want to be sure that we don't hand back a bunch of general funds because it seems to me that we're very lean as we are and.
Right. Right, so at this point, if nothing changed, which is exceptionally unlikely,
Yeah.
it would be $80,000, which is sort of what we have.
Right, and last month it was projected at 144, so the other 60 has gone into these, maybe the increases in
Yes,
those
correct.
25%. Yeah,
Correct,
okay, which seems very reasonable, thank you.
okay. Any other questions? No, thank you, everyone.
Great. So, as I mentioned in the introduction, the bulk of our discussion today is going to be about our revenue strategy. And before we dive into that, we thought it would be useful to just sort of refresh your memory about some information that was presented to this board very early in our work, more than a year ago, to just kind of reorient us. And I know we have new board members since that happened. So we had a presentation by the Legislative Revenue Office about the general state of taxes in Oregon, and that was to help ground us as we got started in our work. And we thought it would be a good time to refresh ourselves with that. So I'm going to turn it over to Lee to review these initial slides.
Thank you so much. Let's dive right in here. So as noted, these first couple slides, I can't personally take any credit for them. That's LRO. These are slides that the board saw about a year ago relative to how Oregon looks with regards to its tax structure. So this figure compares both on a US average and then Oregon to a couple of its closest neighbors. And as you can see, relative to kind of its peers as well as the nation as a whole, we are a state that is heavily dependent on the personal income tax for the majority of our state revenue. Slide. When we look at that personal income tax burden, again, compared to all of the other states in the nation, we can really see the effect of having a state that is so reliant on the personal income tax for that revenue. We do have one of the highest personal income taxes in the nation. And this is not only with respect to kind of that top tax rate. So if you happen to be in a top tax bracket, if you actually look at how quickly it scales up, we have one of the highest rates, even for individuals or households that are making, you know, 60K a year. So even for kind of a modest level, our personal income tax burden is way up there.
And Lee, I just want to pause here for a second on this slide. I just want to point out that we're already, as Lee said, so really high in regards to other states with our personal income tax. If our revenue strategy as it stands passes, we will easily be number one in the country, easily be the top state for income taxes, just something to consider.
But the only state with universal health.
It's true.
Slide. All right, so I wanted to take a look and kind of expand this out to what does the kind of tax environment look like for businesses in the state of Oregon. And as it turns out, Oregon also fares not particularly well when it stacks up to other states as far as kind of being a business-friendly tax. We do have a fairly large amount of our business tax burden. It is 5.4% of the private sector GSP, which is about a little more than 1% higher than what we see as a national average, which is 4.2%. Or sorry, that's a pretty substantial increase of more than 1% from what was 4.2%. Notably, a few years ago, Oregon passed the corporate activity tax, and that has had a really substantial impact on how business-friendly our tax structure is seen to be.
I wasn't sure if people saw that Michelle's hands been up for a while.
I did not see that.
So sorry to interrupt. This is really helpful information. I'm just seeing a note from our Spanish interpreters that they're struggling a little bit with the pace of how fast we are speaking. So just not directed at you, Lee, but reminding all of us to try and talk as slowly as we can. And thanks so much.
A good reminder for me as well.
Thanks, Michelle.
Thank you, Lee. So after I saw this stuff, I this week had conversations with a couple of friends who were business owners. And I said, you know, look at this. And they said, yeah, but we don't have any sales tax. And so I'm trying to figure out how to put this in a context with where we have apples and oranges. Because you're absolutely right. I mean, if we have even a minimal increase, we will be toward the top. At some, I know that prior to my arrival, you all have debated this and thought, oh, you can't bring up a sales tax anymore. So I just want maybe that to be noted at some point, somebody needs to maybe consider revisiting that.
Yeah, that'll be part of our discussion.
Great,
With
thank
the
you.
revenue, yeah.
Thank you.
Go ahead,
I'm
Mary.
just catching up. Thank you.
The
very
other
much.
thing that doesn't appear to be here, and I can't give you the whole history, et cetera, but the property tax, Measure 5, that happened long ago, really benefited business. And it put the burden of paying for our local stuff, schools, et cetera, on the backs of the individual homeowners. So I think that also has to be looked at, that when everybody goes, we have this terrible inequity and charging business, and it's a bad place to do business. If you've got buildings, if you've got whatever, you got a real break, and it still continues to cause havoc with our education and other kind of things. So just,
Yeah,
that's not in here.
well, sort of it is. The facts and figures that Lee is going over is from the Tax Foundation, and they consider all taxes in the states. So it's not just business taxes, it's just sort of the tax environment for businesses. So it includes
Okay.
property taxes, sales tax, corporate activities, corporate
okay.
income tax, all of that is included. And so I'm gonna let Lee kind of keep going here, but yeah, and then there's
the next slide.
right, they do consider all taxes in the
And,
state.
and what I just want to note from this, it's less about the exact ranking and more about the change in ranking that I really want to highlight here, because taxes are really complex, and depending on who you're having ranking, they're gonna weigh different things. But I think the takeaway here is that Oregon was ranked 21st, so we'll say it was middle of the pack. It was average with respect to how businesses fared. It has fallen to 39th on this particular survey. So, you know, as you look across different people who survey this kind of thing, you see there's been a pretty substantial drop in how business friendly Oregon's tax structure is seen to be. And that's really kind of the takeaway, more than just, you know, exactly what number are we? We've had a pretty substantial drop. Next slide, please. There's a lot on here, but just noting, kind of going back to that whole tax environment. There are a lot of taxes in Oregon, even beyond just that personal income tax. This one is looking at kind of the sum of all those taxes. For those of us that happen to live in Multnomah County, we're even more heavily taxed. In fact, Portland, as it turns out, is the second most highest metro area taxed after New York City, which is pretty astonishing in my view. So we are a state that, yeah, we turn to taxes a lot. We've used them for a lot of really great things, but the burden is real. Next slide, please. And so as we are considering something that a plan that would involve, of course, some tax changes, did just want to quickly touch on what that means from a legislative perspective. The legislature can pass tax bills just like any other legislation, does not necessarily require any kind of public referral. We'll get to that. One thing that does matter with respect to a tax bill versus, say, another kind of healthcare bill is that something that raises revenue does require a 3/5 majority or supermajority in each chamber rather than a simple majority in order to pass. Now, like I said, the legislature can pass a tax law the same as they would anything else. In Oregon, we do have a referendum process though, which means that voters, if they can get enough signatures together, can actually bring something to a public vote. So they can require this extra step. And Oregon voters, very legislatively engaged, they do often use this process, especially where revenue is concerned. So in this instance, if enough signatures were acquired, it would go to a public vote, and at that point, a simple majority would be required for that to actually go into law. Slide, please. And I did just want to note some of the different attempts to raise revenue over the last 25 years. These are some of the most notable ones. As you can see, looking at that process, a lot of them did go to a public referendum. So, like I said, we've got a really highly engaged electorate, particularly when it comes to taxes. They often want to weigh in. We do see there's a real hurdle to consider with respect to getting over that 50% threshold. Of these 5, 2 of them did pass. They were 2 of the more modest ones, and that corporate activity tax, of course, being on businesses as opposed to on individuals. But most recently, measure 118 failed pretty strikingly, 77% voting against that. And again, that just to note, that was for a really large amount, so that could also have something to do with it, but
I'll jump in here too. Yeah, so measure 118 was a corporate tax and that was 2024, but the board may be aware that just in the most recent session in 2025, Oregon's been trying to pass a transportation bill. And the pathway of that bill has been absolutely stunning in terms of, you know, the support that it had initially from the governor and the legislature, the process of getting it passed, reducing the amount, reducing the tax. And then passing and getting signed by the governor, and now the governor is requesting that it be repealed because there's been so much opposition from this referendum process. There were enormous amounts of signatures in opposition. So trying to get a transportation package passed with a small gas tax and some increase in fees has been a really big lift just in the past year. So we are in an environment where new taxes are seen as a really big lift for our state.
thank you so much for that. And I will,
I-
oh, apologies.
I also have read that in that referendum, some things were included in there that were not included in the regular bill. And that is part of the reason the governor, you know, it would, of course, it would do it worse than is current or something. So it's not just.
Yeah, no, it's complicated.
Yeah, it's complicated, but I agree with you that it's a lot of sentiment out there for a very small increase in taxes.
Right.
Right, next slide. All right, and then Mike, as you brought up, the sales tax is sort of the kind of elephant in the room when it comes to Oregon tax structure here. Just a note on sales tax, part of the reason there is so much resistance to it, there is this little blurb in the Oregon Constitution that a lot of advocates like to point to as a reason why a sales tax is illegal. I'm not saying it is, I'm just saying that there are, you know, definitely legal barriers that would have to be overcome. Folks would absolutely bring a challenge. And one important workaround, just with respect to, as we've been thinking about our own tax structure and, you know, potentially like premium tax, for instance, is having that acknowledgement or exemption for low income residents is really crucial to avoiding this particular provision. So it's absolutely essential, and this is already baked into the revenue plan, of course, just having that acknowledgement for the low income individuals. And with that, I'll turn it over for discussion.
Anyone else have any comments or thoughts on sort of the tax issue before we move on? Go ahead, Mary Lou.
Just that it is always argued and is true that a sales tax is a very regressive tax. And I don't know if there's a way, like with this, you know, little duck here.
Don't really know what I was
Okay,
thinking.
okay, anyway, big feet, okay, footprint, okay. But really, how, you know, as states do their sales taxes, you know, they try to not tax things that are essential, food and those kinds of things. So that helps people who low income, that those are the things they buy the most. And so all of that, but it is, that's been the biggest argument from the advocates on the other side continually, is that this is the most regressive tax around. And Oregon does not like to see itself as progressive. At least that's my impression of what my years of being there, okay?
Okay, great. So then just briefly, I wanted to go ahead and advance the next slide. Just look at some of the principles. We established these early on in our work, and it's just a good opportunity to just revisit them quickly, refresh our memories about what we agreed on.
And
Where our guiding principles. Yeah, and Amy has provided all of us with a laminated copy. Go ahead, you want to?
Yeah, and I just, I laminated it so that we can leave it here and it can get clipped with our name tags to be reused, but then it's like in front of us as we do decision making.
Great. Go ahead and advance. As listed on the slide and now on our beautiful laminated documents, these are the 5 overarching principles that this board came up with for the Universal Health Plan. They are health equity, maximizing health, fair distribution of medical resource, minimizing financial hardship. We specified here that we wanted to minimize financial hardship for individuals and families. In our discussion about our preliminary structure, we also did mention businesses in there, that part of our role is to really think about financial hardship for businesses as well as individuals and families from medical costs. And then the community sense of ownership and governance. Go ahead. Yes, ma'am.
question, when you bring that up, should somehow that be revised to actually say that in this?
It is in some documents. It's one of those things that keeps, it gets shuffled in that, but yes.
But I'm wondering for, like when we have it on the website and that, as everybody starts really getting real about this thing, we might want to put and businesses, because I know that's been a big thing that we've looked at in the F&R committee, is how to exclude those small businesses, et cetera. So I'm just wondering whether that would be something you want to do.
Yeah. Make it a quick reaction from the rest of the board members if we feel like officially modifying this to include businesses as well as individuals and families. Anyone have thoughts on that?
I'll speak. I think for us to be really looking at our affordability thing, we've got to look at how it does affect business. And that doesn't mean we shouldn't be progressive, we should. But at least the businesses, and again, this is a small sample of conversations I've had the last 2 weeks. This is just January 6th. I think that would be seen very, very favorably. So my initial reaction, haven't thought it through.
Would be to yes, to include it.
Yes, to include it.
Yeah, go ahead, Michelle.
Thank you, Chair, and thanks fellow board members for this discussion. I guess I feel a little uncomfortable just about the process of kind of ad hoc changing our principles and values. There was several months of really serious work, reading a lot of documents, reviewing values and principles from other efforts, reviewing state law and constitutional requirements. It was a very, very thorough, thoughtful process that involved many board members. And so I think all of our documents are living documents. I'd be open to re-looking at that, but I think just doing it very ad hoc to me doesn't feel like it respects the process and how serious these are. And then I think we would really have to think about what is the definition of financial hardship and what are if we commit to, anyway, I think it's a much bigger discussion than a simple edit, I guess, from my perspective. I would also just say we have simplified this for easy reference, but this is a much larger, very detailed document that is not very accessible. And so I think it might be helpful to send board members the full principles and values work product that the subcommittee came up with, because I think that might answer some of those questions. And then it might be a question of just is there something we need to tweak in terms of what we're bringing forward in the simplified version that's easier to reference and keep front of mind. So those are my initial thoughts. I was part of that subcommittee, which is why I'm speaking up here. So I appreciate the suggestion. I guess I just think it needs more thought and more process than an ad hoc change at a board meeting.
Go ahead, Cheryl.
I do agree with Michelle's view. I wouldn't want to vote on that just
No.
now immediately. The only other thought I had is that if we were to change it, I would feel more comfortable with employers than businesses because the whole intent of our revenue plan is, or of universal healthcare is to separate the benefit from the employment. And so I think that is maybe a better word to use if we were to change it at some point.
Just to make sure I'm clear, because there are businesses that are not employers or it's just their role in providing the benefit.
I think businesses is kind of a broad word, and I would certainly want to minimize financial hardship for small businesses. And there are other businesses that are kind of getting away with not paying into the benefit system right now. So I feel like employers is just more accurate in terms of not having the benefits through the employment. But again, I don't even want to vote on it today. I'm just bringing that up.
Okay. John Wayne?
Yeah, I also agree with Michelle's comment and concern. And also on this fourth principle, the specific financial hardship is related to medical costs, not overall financial burden. And so in terms of medical costs, it's largely bear by individual family, not by business. And indirectly, if we are successful in implementing this universal health plan, in the long run, it's actually indirectly reduce the financial burden of business or employer related to medical costs. And so that's deserve more serious consideration because this is very specific on medical costs, not on overall financial burden.
I'm not sure that either of those things are true. I think that employers pay a huge portion of healthcare costs, and my understanding, not being an expert at this, but my understanding is our current revenue strategy makes the costs to businesses neutral, that roughly they'll be paying the same under a universal health plan as they pay now. So I'm not sure how much benefit, other than relieving them of the burden of supplying that healthcare contract. But yeah, it's something for sure to consider. I'm not sure who was next. I apologize. Amy, go ahead.
I agree with Michelle. I was part of that subcommittee. And there was a lot of thought put into it. I also think we want to be careful because I don't know, depending on like what decisions we make, if we add that, if it could be weaponized back. Just a thought, but I think it bears more conversation and really looking at the full document.
Okay.
All right, Mike, I think
Mike,
Mike was
go ahead.
next.
Yeah, thanks.
Well, I just want to demonstrate it's good we're having dialogue because Amy and Cheryl, what you said makes total sense to me. And I'm going back to my comment, that it was regarding small business. It wasn't regarding giving Walmart a break or whatever. Yeah, so I am perfectly comfortable with us entertaining and looking at this and kind of reminding us and for people that I'm the newest person, I mean, I appreciate the history and I have nothing to add there other than there's clearly a spirit anyway, from what I understood from your previous work, that there is a sensitivity already to small employers, and I applaud that.
I guess I'm just going back historically to when the Oregon Health Plan came in and we were MCOs at the time, not CCOs, but Care Oregon was the thing that I helped get off the ground. And it was difficult, just like we're struggling with this kind of stuff. We had these kinds of discussions on basically it gets down to where's the money, how much is going to who, and follow that money. And when we were having those very difficult discussions, unbeknownst to us, or we hadn't planned it this way, the very first meeting we had of the group that was gonna OHSU and Multnomah County coming together, we came up with principles and values. And it brought warring factions together to see that we had really similar values. And then when it got down months into the process of deciding if there's a dollar to spend, how are we spending it? And it was heated, trust me. We went back to the values and principles and said, if we really want primary care and prevention, which was one of our big principles, then we've got to put more money towards it. We cannot continue to pay hospitals the same amount and, you know, it'll never change kind of thing. So I just became a real believer in when it gets going and it's hard, that the principles and values probably will be the thing that we could go back to and say, does this really do these things? And so, you know, I don't have any big deal about employers or business. It was just your comment, Helen, that they really aren't even referenced here. And we are thinking about them in how we're putting together the revenue plan. So it just, you know, I don't have strong feelings, but I really think, and I'm so glad you did this, because what we ended up doing was having a large flow chart where we had the values every meeting sitting in front of us, so that we would go back to, oh dear, this decision, it really contradicts this value. And so I think, however this was put together, I commend you. I think it's great. And I think it will become more and more useful as we go down the path.
Yeah, that's exactly why I wanted to revisit it. We just look at it. So I appreciate the discussion. We won't vote. We're not going to change
No.
anything about this now. But I do hope that as we think about our revenue strategy, that we consider the impact on businesses as well as on families. And we can leave it at that for now. Go ahead. This was a document that the Finance and Revenue Committee has to guide their discussions. And it sets the framework for a sound financial plan. I don't think, they mentioned here avoiding economic hardship. And then, of course, considering the ERISA legislation and how that might play into our decisions. Next slide. And then Echo Northwest put forth this memo with principles for a viable and just financial strategy, including equity and progressivity, fiscal stability and permanence, scalability, legal viability. Some of these may play into our decisions as well. Does anyone on finance and revenue want to comment on these approaches, or what you're thinking of? Mary Lou already did a little bit about considering the impact on households and businesses with our revenue strategy. Reflect on how these principles might influence our decision today.
The one I thought maybe to clarify, because when I joined the Finance and Revenue Committee, it was already far down the track and I was trying to understand things. And the one I didn't understand real well back on the Finance and Revenue Committee guiding discussion document, the slide before this, avoid cliffs. I didn't understand what that was, and it was really around employers. The fact that if you made it that you excluded, say,
50 employees and above.
yeah, a small amount of employees, and then they didn't want to hire the 51st.
Right.
So anyway, that was just for people who weren't in that discussion.
Right.
That's what it meant to me.
Go ahead, Charlie.
I just want to caution on the last point, economic neutrality and efficiency, and specifically on the term efficiency. That's a very normative term. And so we have to be careful, what does that mean? Because efficiency can be defined in dozens of different ways. And so maybe down the road, we need to be clarified, what do we mean by efficiency?
So what do we mean by efficiency?
Cheryl,
Not clear to me.
this is a discussion that was with Echo Northwest.
This was Echo Northwest.
Okay.
I can't.
But the board, I think the board need to define, if we want to adopt this, right, the board need to define, what do we mean by efficiency?
Yeah, I need to go back and look at the details. And I also think we meant something beyond what you just said, Mary Lou, or
Cliff,
Yeah.
did we?
like a fiscal cliff, but I'd have to go back and look at it.
The mainstream field of economics still dominated by the neoclassic sense. The neoclassic has a very peculiar definition of efficiency that they mistakenly thought is a positive concept. It's an objective concept, which is totally subjected to the court. But because it's the dominant, the mainstream, they even think that's a default definition of efficiency, so they don't care to define it. They think everybody accept that. That's why I caution that. The term efficiency is just like equity. It's a totally subjective phenomenon.
Luckily, Morgan Shook from Echo Northwest is joining us at this meeting, and he has his hand up, hopefully to give us some clarity. Go ahead, Morgan.
No, great questions. And just to clarify, the two pieces, the first slide you have on the FNR and the one you have up here are the same piece. What we did was basically take that original document and just separate it out into a few different components. There were kind of principles as well as some methods and perspectives. So we just wanted to make sure they were separate. So the question on economic neutrality and efficiency, the principle there is to minimize adverse economic impacts and preserve the federal tax preferences wherever possible. And so the way the committee operationalized that thinking is kind of in four questions, right? Does the proposal have adverse impacts on employment, wages, business costs, productivity? And is there a way to measure that? Are there risks on individuals or businesses relocating due to the revenue structure? Are there any weird interactions with other kinds of tax preferences that may be at the federal or state level? So things that may impact employer-sponsored insurance provisions for like ERISA, and then with respect to kind of neutrality, right? Can we design a proposal that doesn't distort employment, the labor supply, the timing of retirement, or other kinds of employer behaviors? So not trying to seek kind of one kind of example measure, but to try to sort of think of the neutrality and efficiency in terms of distortion with some of the broader economic and social outcomes that the group has been paying attention to.
So Morgan, if I understand right, the idea would be that whatever plan we implement, we want it to sort of be as seamless as possible, for lack of a better word, that if businesses were going to implement it, they wouldn't have to make any dramatic changes.
Exactly. I think the idea is not to try to, design a plan where we bring in the sort of dreaded unintended consequences of the proposal.
Okay, so that's what's meant by efficiency in that context, that it's the plan is efficient in its implementation for businesses.
Correct. Well, and households.
And households, yeah.
Yeah.
That's not too far out of the, right, okay. Thank you, appreciate that. Go ahead, Michelle.
Thank you. I'm appreciating this conversation. I guess one question I have is, it seems like there's a tension or a trade-off between being efficient in what Morgan Shook just laid out, where it's seamless for existing systems to transition to our plan, versus which the current systems are so complex and fragmented and redundant, like we've talked about for years, which means we would have to, in some ways, match some of that complexity, which is what I'm seeing in some of these proposals. And then I wonder how that impacts the administrative savings potential for our plan. If our plan is focusing on or emphasizing bridging to current systems, then does that mean that we are retaining more complexity than most universal plans do? And does that then reduce the amount of savings that we can realize in terms of administrative burden at all levels? Does that make sense?
Yeah. Morgan, do you want to address that, or?
Yeah. So, Michelle, if I understand your question here, is like, we have a very complex situation that we have today. So we're trying to minimize the complexity to be as simple as possible and transparent, but that inherently means some level of complexity. And I think you see that in the proposal with the sort of how we phase in when taxes start, who might be exempted, how credits might work, right? Those types of things. And so I guess the question here is, you don't want to design a system that's administratively complicated and expensive to administer. And so the group has been paying attention to that. And this is kind of why we're trying to operate within the existing sort of tax structure by using kind of new added rates. So basically, nobody has to file a new type of tax return, right? It's already part of the existing tax return you do, whether you're an individual or a corporate entity. And so that helps limit sort of the administrative cost, like versus if the state were to sort of implement a sales tax, right? There is a brand new administrative structure and reporting collection system that would have to be stood up in order to sort of account for that, which then reduces sort of the net sort of revenue that would come from the tax, because you have to account for that sort of administrative sort of a cost. So I think hopefully that sort of, if I understand your question, is part of that. Here is like we have systems that are already collecting this, and this just changes the amounts that people are paying. On the flip side, right, the administrative savings around being a single payer is a question that the group is still kind of working through. Like, what is that amount, right? We don't have to have the same type, we don't have to, by hopefully centralizing the payment structure, the current cost of doing, billing, A&R and all that kind of stuff could be more streamlined and simplified between providers and ultimately the insurance pool that is provided by the state. We have, as part of FNR, there are sort of thinking about what that could potentially be based on work that was done by Optimus, but it's still, I would say, kind of an open question exactly what amount that might be.
Yeah, thank you. I'm just as a through line, kind of an overarching theme and tension that I'm noting that I just want to put out there and that I'm wrestling with is the trade-offs and the tightrope that we're walking between trying to bridge to the current system, whether that's the tax system or the healthcare system or the billing, whatever, all the current systems, so that we can make that transition, and then what we might lose in terms of efficiency from a really true universal system that we see in other iterations. That's a tension that I see kind of at every level of the proposals moving forward. And I just want to raise that for my fellow board members I look forward to your thoughts as we move forward.
Fenway?
Yes, I just want to clarify, I'm not advocating a particular form, particular definition of efficiency. And Amartya Sen was the first economist to point out the term efficiency is normative, subjective, because there are many ways to define efficiency. And more specifically, when economists use the term efficiency, most often there are two major types of efficiency. One is called allocated efficiency. And that's when economists invoke term efficiency, most frequently referred to, but they don't use the full term allocated efficiency. They simply use the term efficiency, and that can be confusing.
What was your first word, excuse me?
Allocative efficiency. That means
Allocated
efficiency. That means when we make policy, make decision, what maximize the social well-being. But then how you define social well-being, that's subjective. And there are different ways, and economists have particular way. Different schools have to particularly define what we maximize social well-being. And because of that nature, the allocative efficiency is totally subjective and normative. But then another term, non-economists usually associate the term efficiency with is economists called technical efficiency. The technical efficiency is once you decide an objective, what is the most cost-effective way to achieve that? When I teach that in the health policy class, I always give this example. Allocated efficiency in health system is what we want to maximize in our healthcare. There's no scientific objective way to define that because it's value-based. But technical efficiency is very straightforward. If we want to improve, say, reduce infant mortality, then the technical efficiency means, given that objective, we want to reduce infant mortality, what are the methods that's both most effective and minimum cost, meaning most cost effective? But we often associate the term efficiency with the second one, technical efficiency. But when most of the time, and what Michelle raised the question, and also we were discussing, is largely related to allocated efficiency. Because when we implement universal healthcare, everything will change. We want to minimize the impact on business, on people's behavior, but then what are our priorities? Things will change, but this is a difficult question we have to contemplate. And I'm just cautioning that the term efficiency has at least two very different meanings. And most of the time it refers, particularly our discussion now, focusing on the allocated efficiency, and that needs a careful thought. And I'm not advocating a particular type, but just cautioning that.
Thank you. That's really helpful. I appreciate that. Mike, go ahead.
Yeah, I actually want to build on Chenwei, so, and I'm so delighted he's back with us. I am struck by the fact that in applying the principles, well, so much of our context is based on insurance models and what I found in teaching global health, whether it's UK or Canada or Singapore or et cetera, is that students have taught me, don't use the word efficiency because you're confusing the hell out of people. Talk about it's simple, it works, it's effective. And that words like efficiency, I'm sorry, but if we surveyed 10 Oregonians, we're going to get 11 different opinions about what the hell that means. So I'm not advocating for changing anything as much as let's not make believe we know what the hell that means, because we don't.
Okay.
And I guess being on the F&R committee and looking at this now, Morgan, you did come in with, you know, our kind of list of what we had said were our kind of principles or guiding the discussion here, and that he kind of cleaned it up, et cetera. And I guess after listening to this, I simply think maybe it should just say economic neutrality as much as possible. I mean, what we were trying to say is that employers are paying right now for an increasing amount every year of premium, okay? And so kind of like where it is, we would like to not have them be continuing to pay more for the same product, and to kind of make that even at now, we've talked about, could it be a similar amount or even slightly less, so that we can help them understand this is better for them, as well as that for individuals. That's the same thing, but because we're going from this system that is, you know, all premium based, all that stuff that we've got, it's hard for your mind to kind of go, okay, I'm paying, you know, 2,000 a month for this. Now my taxes are going to be this much. And so I just don't know that we really need the word efficiency in this context. I don't think it was something I understood. And Morgan, you can argue with me or others on the committee.
Well, we don't have to get into
Yeah.
it, but I think Morgan's point was like, if to the extent we're gonna keep it neutral with employers, and the extent that we collect the money, the idea is to collect it in a
In an
way that
efficient
is
way.
familiar.
Yes.
Right, and that's what
Yes.
efficiency,
I,
a
okay,
payroll tax, as
Yeah.
opposed to a brand new
Yeah.
sales tax,
okay,
right?
so yeah,
If
that's,
I understand right, that's the role of efficiency in this,
Okay.
like, do something that's
it's just
not,
the word, I guess, if it
Right.
raises all these
Right.
questions. I don't know,
Right.
but
okay, let's.
There's a specific definition of taxation efficiency. The taxation efficiency simply defined is the amount you collected versus the cost of collecting that. And that is more on the technical efficiency, not only allocated efficiency.
Okay.
good discussion.
So I just wanted to bring up too, that, currently in our healthcare system, there is to some extent an element of choice. Some people, when you're choosing a plan, either through your employer or through the ACA marketplace, people have choices. They make choices depending on how much they anticipate needing healthcare resources. They make choices based on if they would rather have more upfront costs or take the risk of having more sort of out-of-pocket costs later. They can choose a plan that has more benefits and higher premiums with a lower deductible. They can choose a plan that has fewer benefits and therefore a lower premium with the risk of a higher deductible if they actually do need care. There's some element of choice there that exists in our system today. Go ahead, next slide. With the universal health plan, we are removing that choice. Everyone will have the same level of benefits. And some people will pay nothing Some people will pay a similar amount to their current contributions, and some people will pay much more than what they currently do. But we are removing the choice from that equation. We're saying everybody gets the same level of benefits, but people will pay differently. So the payment of healthcare is going to shift a little bit from utilization or anticipated utilization to purely based on your income. That what you pay for healthcare won't have anything to do with how much healthcare you use. It'll just be how much income you have. I'm not saying that's a good thing or not a good thing. I'm just pointing it out that that's something that we should keep in mind, that we are removing choice from that, and we're removing the element of utilization influencing what you're paying. So go ahead, Amy.
I think it's a false choice as someone who's self-employed and buys through the marketplace. For years, since the ACI, bought the gold plan, making that calculation. This year, because of removal of the tax credits, I no longer had that choice. I was priced out of having a choice. So 3 weeks ago, when I went to physical therapy, I had a $20 copay.
Right.
Then January 1st, $145 towards my $7,500 deductible, which, like, when I made that choice, I somehow didn't see that particular specialty
Right.
was.
Right. Yeah, no, I appreciate that.
So it's not really a choice because you get priced out.
Well, I appreciate that. My point here is that those choices exist. There are bronze, silver, and gold plans. Those choices exist, and in theory, one could choose it if one had the resources to choose
Yes.
it. Those choices are presented to people, and then you have the ability to pick one. We are removing that leveling. We're removing that completely and saying that everybody gets the same level of benefits. I'm not advocating that that's good or bad, but we just need to be aware of that and that how that might land with people, that they no longer get to choose. I know a lot of people choose a high deductible plan because they don't anticipate needing much health care and they would rather save that money. And so we're eliminating that and saying you must pay this tax and must have this level of benefits, regardless of how much health care you use or anticipate using. Just to kind of put that on our plate. Next slide. But, so these were removed, so this isn't the correct, go ahead, sorry, you can keep going. Okay, so, we're going to, move into the discussion of the revenue plan now. Mike, did you want to make a comment before we start?
Oh, just really quickly, I'm hearing all this discussion, but as someone, I used to be a health plan manager. There is something to Amy's point that, most research I'm aware of is that this choice of health plans is really kind of a BS choice. That's not the choice. The choice is whether or not you have other options as a patient. And with the universal health plan, of course, I mean, that's the important point. Who cares whether or not you have choices in a health plan? What people care about is what is your access stuff, if you will. So I can certainly defer that to later, but that is an argument that some of the classical for-profit health plans used before. I don't think we should buy it. Just
Okay, go.
I just think choice is a loaded word.
I do too.
And I think I would avoid kind of framing it as that because of the things that we're talking about here. And it just brings up, in women's reproductive care. I mean, it's choice is a word that has a lot of connotations to a lot of people. So I'm just kind of like,
So
not wanting to see them taking it away.
I'm gonna push back a little bit. If you work for a large employer, they might offer you a choice between going with Providence or Kaiser Health Plan.
Right.
They might give you the option, if you prefer, of covering just yourself and your spouse, yourself and your children. Maybe you're just gonna cover yourself and your spouse's employer is gonna cover the kids. There are some options available to people in how
Options.
much coverage they get. If you don't want me to use the word choice,
I like
but we
options.
no longer give people any options.
I understand that.
Right.
I do.
I think that's important.
Politically.
I think we need to keep that in mind, that we're not giving people any options with this.
Okay.
Okay, go ahead. Go ahead, Tommy.
I have a quick comment. Yes, choice is a complex word. And based on the previous research among Americans who have employers that sponsor health insurance, more than 80% of those have no no option, no
choice.
choices.
Mhm.
Their choice is take it or leave it. But then, the more important point I want to make is choice is a loaded word, but we have to build defense because one of the potential attack from the commercial insurance is with universal health plan, we give people no choice of plan. So we have to build that defense.
And how do we think that'll land? Right? Like, right, how do you think that'll go over? Okay,
All right. So, what I'd like to do at this point, I am going to present sort of the state of the revenue plan as it's being presented and brought forth from the Finance and Revenue Committee. And I'm going to highlight decisions that have been made by the board, decisions that are pending by the board and still need to be made, not necessarily today, but potentially some of them. And also when the board has not yet made a decision, making it clear as much as we can what the Finance and Revenue Committee recommends. After that, Morgan is going to go into more detail. And after that, Cheryl's going to bring us home with kind of bringing forth again those issues that are not yet resolved, but which potentially can move forward today with either some yes, no votes or even some more specific votes. So that's sort of the order of operation for what we're going with. So if you'll go with the next slide. All right, so look at all those stars. Nice work, people. So the current revenue plan components are, as it stands now, there is a healthcare personal income tax, there's an employer payroll tax, corporate income tax, corporate activity tax, and a lodging tax. Obviously, just say stars. In other words, this is, yes, we agree. Those are some of the revenue choices that the committee and the board believe are the correct way to gain revenue. You'll also notice on the side, there is EPT, apologies for the acronym, but stands for Employer Payroll Tax Credit, which again, the board has decided they would like to see that. They haven't decided on an amount. And the Medicare Part B premium credit, actually, the board decided yes, and did decide on an amount, which is 100%. So I'm going to get into some more details. Also, I just remembered Michelle's comment about talking too fast for our interpreters. So as I see Michelle's face, so I'm going to slow down as much as I can. I know we have a lot to get through. Yes, please. I'm sorry. I think Fabio raised their hand. If our interpreter can,
Can you show that again?
I'm sorry. I'll ask Isabel to work with the interpreter, and I will work on myself to slow down. So we'll move on to the next slide. Oh, you said mistake. Thank you. All right. So this first slide talks about the Oregon Healthcare Personal Income Tax. On the left-hand side, I have kind of components of that. And then I have on the right-hand side, a board decision TBD, standing for to be determined, or yes. So we'll go over these one by one. The big blue stars are what we are hopeful that the board will be able to make some decisions on today. So the very first thing, we know that the board has decided, yes, a healthcare personal income tax. That's a yes, that we do want to have that revenue. The first row across says income level at which the tax starts. Another way to say that is the exemption threshold. So the board has not yet made a decision on that, and Morgan is going to go into much more detail about this. The way that the Finance and Revenue Committee has been speaking on this subject has been phrased as the ownership, as an ownership question. We're working on the nomenclature for that. So really what we're looking at is, will individuals who are on that within 0% federal, 0%, 1% federal poverty level up to 200, at what income level would their taxation begin? Or in other words, at what income level does the tax exemption end? So right now, what has Finance and Revenue has utilized Richard can't see me, but I'm looking at him. I want to make sure I get this right, but I did confirm. Finance and Revenue is utilizing what's called a phased in flat rate. So in other words, the income tax starts at this point, the way the plan looks like, at 200% federal poverty level, and it goes, it phases up to whatever the final percentage will be, and that is not what we're going to determine today. When people get to 260% federal poverty level, there are other components in the structure that also contribute to how much people ultimately pay. But I just wanted to bring people's attention. The main question is going to be, does the board believe that they would, that is appropriate, or that they would prefer individuals start paying into the, paying income tax, healthcare premium, income, personal income tax at when they're essentially their first dollar, put that in quotes, or at some higher level. So that's number one. And again, Morgan's going to go into a lot more detail about that. So I'm just going to keep rolling along. Again, healthcare, personal income tax are now down to the next row. Yes, there should be one. What will that rate increase be? That's not known yet, because there's still a lot of other variables, and that's definitely not what this group is trying to determine. And then what the question is, again, as I said, Finance and Revenue currently is utilizing this phased in flat rate with a phase in, as I mentioned. Other people have brought up, and I want the board to be clear, that that is not a marginal rate. So it is not, which is what our federal income taxes might be. If you have an income level at this, you pay this percentage. If it's higher, you pay that. I'm looking over at Richard, and I'm going to ask him if I explained that correctly.
Thank you. Two things I'd say is that the 200% of federal poverty level is where the personal income tax rate starts.
Right. That's the way it's proposed right now. That's
Right.
what I'm saying.
Right. The 260 federal poverty level to 520% poverty level defines that range at which the family size readjustment rate kicks in.
Thank you.
So that's where the 260 comes from. And that's 260% of FPL to 520% of FPL.
60. That's for the,
Family size rate readjustment.
thank you. Thank you. Oh, yeah, sorry, I had that. Thank you. It looked like it got cut off a little bit. All right.
So sorry, just to clarify then, whatever we decide the HCPIT is making up 9% right now, 9% starts at 200% of the federal poverty level, right? And then starting at 260, it would be 9% plus a little extra if you have more family members you're covering.
Correct.
Okay.
Thank you. All right. Next, and this is again another topic that I know people have brought up, the issue, it's called a soft cap. So the inference being that at ACE, when people have paid a certain dollar amount, is the way that's being evaluated currently, of that healthcare personal income tax, once they have gotten to a dollar amount, and it could be, that would be determined, instead of they're continuing to pay at the same percentage, we'll just use 9% again as a placeholder, after they have paid in either 30%, or sorry, $30,000, or maybe it's $50,000, then their tax rate on that income after that could be lower. So that's the idea of a soft cap. I will say that the board has not yet made a decision on that. Finance and Revenue has made a recommendation of there not being a soft cap. And again, Morgan's going to go into more detail, so we'll wait to get to his slides. And then thank you, Richard, for clarifying where the household size rate readjustment begins. I was incorrect on that, and that begins then, you said, at 260% of the federal poverty level. So apologies for that. I used an old one. All right, so I'm going to stop there. And Mary Lou has her hand up.
I just want somewhere a clarification that the 200%, if we're going to get continue a Medicaid waiver and have Medicaid, we could not go down to starting it at zero. My understanding is that 138% of federal poverty is where below that is Medicaid, and that we cannot charge.
You can.
You
We
can
can?
actually, you can, if you get a waiver, you can.
But-
There are waivers that, so it would
Okay.
involve getting a waiver that goes below 138% poverty level, and I'm not, so
Okay, I
it is,
misunderstand.
it is within the realm of possibility.
Yeah.
But we looked into it and you can't, states
You can.
can charge, even
Red
down
states
to,
do.
down to
Okay.
zero.
Yeah.
You can.
Okay, thank you.
So, no, that's an excellent point.
Clarifying.
Okay, so just to hold those two thoughts in our head about possibly talking about this exemption threshold and possibly talking about soft text. All right, we'll go on to the next slide. All right, this one, you'll see there are no blue stars. I'm gonna go over a little bit quickly about the fact that the board has made a decision about there being an employer payroll tax, that there is actually a payroll threshold, the board agrees, and so what that means is that and the Finance and Revenue Committee recommends that a company or a business not have that payroll tax implemented or instituted unless they have, and I'm gonna have a payroll of 500,000 or more annually. I'm looking at Richard again and Cheryl, making sure I said that right. Correct. Okay, so the amount that F&R is recommending is 500,000, just so the board understands, haven't had a vote on that. Individual wage threshold to not tax businesses if their employees are making less than 100% of the federal poverty level. The decision was made that no, employers paying low wages are still required to contribute. So next, corporate income tax, corporate activity tax. Those are both yeses, and the rates TBD. So any questions about those? Yeah.
So there are some parts of this grid where there's no decision being, I mean, a decision hasn't been made yet, and you star it, meaning that's something we need to discuss. I'm not sure, like, on this slide, there are several decisions that haven't been made.
Correct.
But,
Right. The big blue stars are just for today.
so it's not that we're not gonna get to these other
Correct.
decisions.
Correct. It's just, I think there will need to be more, so it's sort of order operations kind of thing. Got to make some of these bigger ones, and then these numbers will fall more into
So
line.
the stars are the priority decisions that we need to make before we can get to some of these other details.
Yes, thank you.
Okay.
Okay, and next. All right, again, these ones, what does light blue mean? Well, light blue means you sort of have decided, but not quite, and a TBD, but again, doesn't need to be decided today. We have Mike's point about sales tax. The lodging tax was a yes, and the board has voted on that. The actual amount still to be determined. And the sumptuary tax, now the board has not made this decision. Finance and Revenue Committee recommendation is that there not be a sumptuary tax, or also called a vice or a sin tax. So tobacco, alcohol, marijuana potentially, which are taxable, could happen. The board hasn't made a final decision. We're not going to bring that up today. Next slide, please. And then the tax credits, you'll notice another big blue star. This is where I hope that the board will be able to come to a decision today. And we actually had someone commenting on this, which is great. Thank you so much. So yes, the board has decided on, yes, there should be an employer payroll tax credit. So that money would go, some percentage of that would go back to the employee. But the percentage of that, I put the range of 30 to 60, which is what I think has been prepared, has not been determined by the board. Finance and Revenue recommends 50%. And then again, the last one, as I mentioned, the decision's already been made and the amount, which is terrific. So stop for a second there. So I'm just.
Right, and so to clarify, the decisions we need to try to address today are the soft cap, whether or not it should exist or not. The exemption threshold, meaning should low income folks contribute, or is there a threshold at which you don't contribute? And then the employer payroll tax credit, how much should that weigh in
Yes.
at? Yes, so those three decisions are the ones that we're hoping to address today. There are others that will come later that we're not going to get to, but just to be aware of the range of decisions. So if we make some decision about, for instance, the soft cap today, it might influence how we decide some of these other things later on, because it will provide revenue or not. that we wouldn't need to make up by these other decisions. So that's kind of the idea of laying all these out first, and then we'll address these three priorities today. And get to the others later. Right?
Thank you.
Okay, good.
Yeah, no, thank you.
Sorry,
know, and
I did that mostly for myself, but.
No, I apologize if I'm
No.
simplifying this too much. So next slide.
Sorry, Mike, did you have a question before we?
Oh, I apologize, Mike, didn't see you.
Actually, it's a comment, and I'm glad you focused this on what the decisions are. But I just want to insert an insight, and that is part of what finance and revenue is doing also includes long-term sustainability. And one of my concerns, and maybe Shenley can speak to this, is making sure this thing is sustainable. It just doesn't work for 1 or 2 years, but it doesn't. There's something, I think, brilliant in some of the work your grouping has done, and that is, ironically, by deferring the decision on sumptuary tax, by saying no to it now, does not mean that someone 5 years from now couldn't bring that up. But so I think it actually you've held some of your gunpowder with the work you've done, whether you realize that or not. It's, I think, fairly brilliant, because you need to have something that deals with not just 1 year, but longer term financing. And I think there are opportunities to do that. So enough of my point.
I'm aware of the time. We could take a break now and then come back and get into these details, or we could start. You want to take a break now? Okay, let's take a break now. It is 10:33 on my watch. We'll come back at 10:43 and resume the discussion. And get started again. So I'm gonna have everybody come back, please. And do we leave the door open on purpose? Or is it-
Just for, I mean, we can shut it. It's just because people are to use a restroom. If we shut it, they can't.
Oh, we have somebody's online with the meeting and it's creating an echo, so please.
Yeah, mute yourself.
Yeah, so mute.
Okay, welcome back, everyone. Yes,
Can you
we can.
Lower the
We got-
volume on your device.
Lower the volume and put yourself on mute.
Is this better?
No.
Lower the volume on your device.
Okay, welcome back, everyone. At this point, we're gonna turn the discussion over to Morgan to get into more details about the revenue plan. I'm sorry, you're gonna have to sign out from this. It's not you, it's him. Okay. Go ahead, Morgan.
Great, just trying to find my buttons here. So I actually, left to listen to the conversation, I actually added a couple more slides actually from our last Finance and Revenue Committee meeting, just I think might be helpful as we sort of set some of the context around the employer payroll tax as well as the credit, just to mimic the thinking. So I think the easiest way quickly is to start, like, why have an employer payroll tax? So I think, well, first of all, right now, majority of workers, right, receive their insurance premiums paid by their employers in a single payer system, right? That would eliminate the need for that. And so one, like, it would just be either kind of a windfall where the employer either keeps it in a single payer system, or they would share that with wages. If they were to share that with the wages, right, that's subject to federal taxation, and that does nothing to help fund healthcare in Oregon under a single payer system. So an employer payroll tax, right, mimics the ESI payments and directs all that business and wage income towards funding the healthcare that was currently in place. So it's just probably an obvious thing to say, but a good thing to make sure to start, because I think then the question is, why have a credit, right? So we'll call it the sort of like the most optimist take on sort of having a credit. It avoids double charging wages, right? So if we assume some of the employer payroll taxes ultimately comes out of a workers' comp, so in the sense of like, well, my compensation for you is fixed in some ways, right? I have to pay for these things, your taxes and other things, and your wages, and so I have to pay more with respect to wages, right? That kind of fix it, and so the credit acts as a way to sort of not have that same wage share tax twice, once as income and then also on the payroll side. And so we just kind of tax the payroll side and we give it back as part of a credit. The EPT, right, and given the structure of it, right, depending on how much is offered, falls heavily on sort of wage earners in that middle income, right? And the credit helps shift some of that overall burden towards higher income, non-wage income, both wage and non-wage income. And so it helps us sort of like provide a little more top end regressivity or overall progressivity in the plan. Another piece, and as we kind of, as the F&R group kind of worked through it, part of the thing that the way that the credit does as well is to help provide some parity between how people derive income, whether that's through wages on the employment side or through if they're self-employed or run their income through pass-through entities. And so here the credit can help kind of, if we look at it from a total tax paid by total income, it can help provide some equity and sort of equality there. And then it also, right, helps us preserve employer contributions while still managing incidents. So a partial credit, right, still has dollars flowing directly from effectively dollars flowing from employers falling to the bottom line, and that we don't use it all for as part of the credit. So big thanks to Charlie here. He did a couple of different things that I think are important for us to understand here. And so just so you know, all this, the rates that we're looking at are assuming the 100% Part B Medicare premium. But the idea is really to understand the distributional effects between wages and non-wages, and also to consider the Medicare population. So this is a wordy chart, but just so you understand kind of what we're doing here. So if you think about that, the teal line there, the lowest green line, right? This is the on the left, we have total tax paid. On the bottom, it's the amount of income. And so as you can imagine, with the healthcare personal income tax, the more income you have, the higher the total tax that you are paying. And so what that green line is saying basically is a sort of hypothetical, like what if the wage earner is really only paying the healthcare personal income tax, right? So we completely ignore the EPT as part of like, a tax paid by them. So kind of think it was like the position of saying like, no, like none of this is ever borne by the wage earner. What would their total tax burden be? We contrast that with the dark kind of teal line there at the top, right? This is basically the full incidence of both the tax, healthcare personal income tax, and the EPT is borne by the worker, right? And so in that situation, you would say, yeah, the amount of income, their total tax burden is pretty high. And so what Charlie did was say, like, let's average that out, right? In that kind of like in between line, and compare it to the total contributions of folks who are in the driving in the Medicare population, as well as the self-employed population. And by averaging that sort of credit in the middle, right, what you see is actually parity between how people are driving their income, both whether those are folks who are on Medicare, or those folks are deriving it through self-employed. So the credit, right, think of it as sort of equalizing the income, the tax contributions across the income spectrum, whether you're employed with a sort of a wage earner with an employer, or you're self-employed. And so then the question is, well, what's the right level of credit to be offering? And Charlie took a look at a number of different ones, but the group was really then thinking about at the margins, right? If you accept that kind of like the credit, it helps sort of provide this like level playing field. The next question is to really say, well, what does it really mean with respect to sort of progressivity within the tax plan? And so what you see in the blue on both sides here is what you see here is a comparison between a 60% credit and a 50% credit. And what you see in the blue is basically the amount of income that comes from the different quintiles in the state of Oregon in 2022. And what you see in the green is the total amount of taxes being borne by that income. And so this is kind of the question of sort of progressivity, right? Within each quintile, are higher shares of income paying a higher proportion of the total tax burden. And what the group took a look at said here is basically, you don't see a whole lot of difference between 60 and 50% of the credit because of the nature of the total, how income is kind of offsetting the total contributions with respect to the productivity of the personal income tax. What a slightly lower credit does, right, is shift just a little more burden basically into your third and fourth quintiles of income in the state of Oregon. So it provides, think of it as basically a lower credit just means that higher earners are still paying a pretty large share and probably not much of a difference in terms of total contributions. And just the third and fourth quintiles are paying a little more. And so this is just another way to kind of look at that comparison between, this is just between 60, 45, and 30 with respect to the effective tax rate by federal poverty level in the tax plan. So we're looking at 130, 200, 200 to 300, 300, 400, and so on, all the way up to over 800. And you can see the effect of the credit at a sort of much lower credit, right? The difference, the margin difference between 60 and 30 is much larger at the highest federal poverty income levels, but doesn't really materially change in that sort of in your bigger portions of 300 to 800% of the federal poverty level. And so I would say and Richard and Mary Lou should probably chime in here. The work that Charlie, Richard were done to kind of help communicate this ultimately led to the decision to land on a 50% credit. I think there have been discussions of maybe targeting 60, but I think 50, I think just as a number sounded as a good sort of middle ground. But Mary Lou, Richard, anything else you want to add on to sort of how the FNR got to 50 after kind of looking at these sort of questions?
I think it was basically that 50% is an easier number for people to kind of do in their mind. And if it wasn't much difference between 30 and 45, et cetera, it just was people trying to do multiplication in their head. And so 50% is an easier number, and it wasn't much different. So it was.
And Social Security and Medicare,
Yes,
employer payroll taxes are split 50-50.
split 50-50. It just feels equal somehow a bit.
Mimi, do you want me to keep moving through to the other pieces, or do you want to stop on the EBT credit?
No, that's.
Oh,
Sorry, bad habit. Thanks, Isabel, save me. No, let's keep going.
Okay.
And we'll just, thank you for calling that out, though. Okay, so that is where the 50% employer payroll tax credit was where Finance and Revenue landed, and then we just had sort of the rationale behind it.
Can we just step one slide for just one moment, Morgan? Just for context, I was trying to sort through this last night. So what this slide means is that with the HCPIT and the EPT combined, if we assume 50%, that people at that 400 to 600% of FPL total are paying about 5.25% of their income for the health plan, right?
Correct.
Okay. And then as you get to that 600 to 800%, they're roughly paying 6% of their income. And then as you get over 800%, they're paying about 7.67% is what I sort of eyeballed it at, right?
Yep.
Okay.
Yes.
And then just for context, 800% of the federal poverty level is $125,000. So it seems like it's a huge income, but when we're talking about so
For
federal.
a single.
For a single person,
Single.
yeah, so for a single individual, that 800% is like the income that you would get to be in that last quintile would be $125,000 a year as an individual. Or household, I guess,
Yep.
because our
correct.
household taxes, so your household income is 125.
But if an individual, it's.
Yeah, because if you have more people in the household, they're.
Yeah, if you have nobody else in the house, yeah, yeah. Okay, thank you, just want to make sure I was getting that right.
Great. Well, I'm going to walk through the soft cap here, and I'll when I get the end, I'll have Richard and Mary Lou help me through anything I might have missed. The discussion with the soft cap, I think, has been centered on that there is sort of some natural tension with the desire to make the tax plan, the revenue plan, make it progressive, while also acknowledging that there is a status quo with respect to how households are currently acquiring and paying for their health care relative to what it would be under a UHP. And with a desire to have a progressive structure, that leads to the implication that some high income payers, right, might be paying multiples for contributing to their healthcare relative to their status quo. And the soft cap was to sort of recognize that and also deal with this question around neutrality, and not sort of lead to sort of the unintended consequences of, distorting people's sort of behavior and decision making. And so what you see here is actually some work that Charlie had pulled from Warren George, just looking at how in the U.S. How healthcare funding is coming from different income quintiles by the source of funding. And so the conversation with the soft cap was about to what extent does the UHP sort of deviate from this structure, particularly given the fact that over 50% of current healthcare payments are coming from the highest quintile. And so this is just some context around how we were trying to think about this with respect to, well, if you have a soft cap start rate, so basically, does it start with a lower total tax contribution or higher tax contribution? What is the marginal rate after you hit that cap? All of that influences kind of what the ultimate sort of cap rate is, because if think of it as raising less revenue in that highest quintile, you have to then balance that out with a slightly higher rate overall, right? And this is sort of the challenge of sort of doing this without a whole lot of great sort of dynamic way to understand it, because we're talking about large increases in taxes. But what happens at the tail end is important because it's a large portion of revenue, but it's also a place where we don't have a lot of guidance of what might actually happen based on kind of the nature of the structure that we're talking about here. So Charlie was able to do some modeling here, and this is just kind of showing the EPT plus the rate by AGI group and the effective sort of tax rates that would be in place. And so what you see there in the bottom there is what the no soft cap would look like, right? So this is the example here where we can have overall lower rates because there is no sort of change in the marginal rate as income increases, right? Once we hit that sort of roughly 10% tax rate, that stays in place from 300 and on. And the key sort of thing to take away here is when we're talking about AGIs less than 300, the soft cap, when it phases in and the relative rate, right, makes a difference, but all within kind of maybe, a percentage point. And so particularly at sort of those, at those incomes there, people aren't, a lot of the AGIs are just starting to tip into the soft cap provision. And so the next chart here is really showing kind of what that inflection point looks like with respect to the overall incomes. And so depending on the scenario that we were looking at, filers were hitting the soft caps, whether we're talking about 20 to 50,000 in the range of like 200 to 375,000 in AGI, and that's where you kind of see those bump points, right? And then the new rate would take effect, and so what you see in the that light blue line at the top right, that's our sort of no soft cap, and it shows sort of our sort of net individual tax rate by those different AGI levels. And then what you see, right, is the stronger the soft cap, the more that effective rate falls as a percentage of total income, which is not surprising, right? Because for every additional dollar, we are taxing that at a lower rate. So the rate of income is growing relative to the total effective tax rate. And so this is sort of like, I think, a key understanding of kind of what's happening in there. So that is just kind of an effective tax rate, and it's also important to sort of balance that out with respect to what's happening with in terms of progressivity as a measure of total income relative to what the revenue would be with the what we're showing is just the
Mark, can I interrupt you for a second?
Go ahead.
Sorry, before we get into this slide, I just want to like pause because this is really complicated.
Yes.
And I just want to see if I am getting this right. So go back one more slide. Just the general idea of this slide is that, so I'm going to look at the around $89,000 of income because that's the median household income in Oregon. And it seems like there's a bump right at 89-ish there in these curves. So if you look at that little pointy bump there at around 89,000. So if we had no soft cap, effectively people making the median income would pay about 8% of their income in tax. And if we add a soft cap, sort of regardless of what it is, like where it starts and how much it is, regardless of where it is, any kind of soft cap would increase the amount that an average household would pay to somewhere between 8.5% and 9%. So if we have any kind of soft cap, the average household is going to pay more, right? That's kind of your general point of this slide.
Yeah, you think of it as like what you're seeing here is actually the phase in of the soft cap relative to where the income thresholds are. And so that sort of bump there right around 50,000, right, is like we have to have a slightly higher marginal rate to pay for the soft cap. And so everybody starts paying a little bit more, and you can see, depending on how you structure it, how much it is and what the rate is, right, that we just have different marginal rates. So what you're seeing is basically effective, just different marginal rates, particularly with households that wouldn't really be subject to the soft cap, with around less than 300,000.
Right. Okay. And then your next slide is showing that sort of the high income people, the folks making in that like $200,000, $300,000 range would benefit from the soft cap. It would not make them paying so much more than the average household. Like it would just bring that equity down, that like they would be paying like closer to what the average household will pay. But at the higher you get in income, eventually the highest income people are going to pay a lower percentage rate than the average income people with any kind of soft cap.
Yes.
All of those lines dip below the blue line, so that eventually at the highest incomes, the highest earners in our state are eventually going to pay a lower effective tax rate, a lower percentage of their income than the average household if there's any kind of soft cap.
Correct. Yeah. So this is kind of the part where like there's two truths here, right? They're still contributing large share of the total revenue, but as a percent of their total income, it's lower.
Right. And what I noticed about this slide that I think is interesting is the rate of rise of the blue line at those high income levels doesn't seem as sharp as the rate of decline with the soft cap. Is that real, or is that like, so with the blue line, no soft cap?
Yeah, I mean, so I think the best way to think about this is a series of points, and that's not necessarily a line, right? But basically, it's trying to understand the relationship. So it's say somebody at $1 million without a soft cap, their effective tax rate would be somewhere around 8.5% with no soft cap, versus in a situation where we started in the green line, right, at $30,000 and a marginal rate of 6%, that effective tax rate would be closer to like 6.5%. Right. And then you can kind of read it up by income. What would their effective tax rates be?
Right. So that's super cool and really helpful. But it's also important to point out that somebody making $1 million would pay $85,000 a year to get healthcare coverage. Yes?
Or to provide
Yes.
healthcare coverage for everybody.
Right, thank you. So it's just that, it's that shift in mindset as we were talking about at the break. From purchasing an individual product for which $85,000 seems like a lot of money. To contributing to a public utility of
Yes.
healthcare, and that your portion of that public utility is $85,000 a
Yes.
year. That's the shift that we're asking people to make, but it's $85,000 a year at those high income levels. Right? Am I, okay,
Well said.
okay.
If their lawyers don't figure out ways.
There's that. Sorry to interrupt you, Mark, and I just.
No,
like-
no, no. That's I know
Okay.
I'm moving quickly through some complicated stuff. And it's good to pause. So this is just another way to take a look at that situation, right, with respect to income, right? So looking at that same chart with the EBT, where the blue is showing the income by quintile, the red line is just showing what it would be with just the personal income tax itself, but it also then shows you kind of with our EBT credit as well. And so this is just a distinction of kind of what happens, right, with no soft cap versus soft cap with respect to progressivity. So with no soft cap, right, we have a pretty strongly progressive system, right, where in that green line, you can see it rising for every income quintile. In a soft cap situation, with a soft cap situation on the right, and this is the example of the threshold being 30,000 and then a marginal rate of 3% afterwards. That drops from the total tax contribution from 69, so roughly 70% down to 3 percentage points to 67%, right? That redistribution of the tax burden in a soft cap situation falls primarily in your third and fourth quintile, which are kind of your larger sort of wage earners, right, with that sort of higher marginal rate. So basically, right, it's this picture here, right? We have to have higher effective rates in a no soft cap situation, but you can still, even with a soft cap situation, still have a fairly progressive system as you kind of measure it in terms of, well, what income is generated and what is the tax contribution by that quintile. So what then I think, as you pointed out, Helen, Charlie put together these scenarios here, and this is just an example of a filer, just one exemption, and what you see is the AGI range, the percentile of that AGI range with respect to income in the state of Oregon, the average wage in there, and then maybe it's the median wage. No, it's average wage. Sorry, I got to remember. And then what you see there is in the employer side, right? So this chart here is basically a constructed metric looking at the status, there's some assumption of what we think the status quo looks like relative to the payments under a UHP across these different soft cap scenarios. And so the green means basically the net savings. So you are paying less under a UHP plan than you would under the status quo. And the red means you're paying more in that situation. And so that first line is the employer side. And so think of it as basically what our assumption, what we think their ESI payments are in the status quo relative to the EPT tax. And then what you see there on the first thing is the no soft cap. And across those pieces of their change in understanding. So think of it as basically in the AGI range from 30 to 35, right? You're at the 44th percentile income. Your average wage is 32,000. Your employer is saving dollars, about $3,000. And then from an employee perspective, you're paying about $1,800 less. From a self-employed perspective, you're paying about $2,800 less. And if we flip all the way down to the bottom in that sort of 250 to 500,000 K, right? That's a 99th percentile income in the state. So kind of an average wage of 33,000. The employer, right, is because of the EBT is paying about $24,000 more in the wage in the EPT relative to their ESI payments. And the employee is probably paying about 14,000 more, and then a self-employed is about 26, and then sort of no soft cap. And then you can see how that plays forward with different soft cap arrangements in those systems. So this is a good sort of distributional chart to kind of understand kind of savings or not, and then a rough estimate of what that magnitude might be.
Can you help me with one thing, Morgan, here?
Sure.
Why would a self-employed person have more benefit? Like, why does that green column go down farther in the no soft cap than it does in the employee? Because I would think with the credit that the employed person would benefit more, like for.
Yeah, so I'll just say I can't remember what version of the credit we're modeling in here. This might be a lower credit, so I think so. Take a little bit of the difference between. Yeah, I would say caveat. Take a little bit of the difference between employee and self-employed out, because this is just an older slide, just to kind of meant to sort of before we lock down the EPT side of it.
Okay, so the thing we should be focusing on, because they kind of,
Yeah.
if you eyeball it, they kind of all look the same with the soft cap. That it doesn't really impact that, the soft cap doesn't really impact this part, right?
Yeah, and part of this is a limitation, right? Because the soft cap's effect is most pronounced in the wages above that trigger point. So we're kind of only, and we don't have a great visibility, but because the impact, that sort of in terms of like status quo versus UHP, are going to be more pronounced in wages in that 1% of Oregonians, right? Where I think in that chart showed basically, right, if you're $1 million, that's probably closer maybe to $70,000 perhaps, as a sort of just off the cuff kind of eyeball.
Okay, thank you.
Great. I'll move us on quick to ownership. This idea was based on feedback, I think, that Finance and Revenue received from this group with respect to progressivity, and particularly, I think, the observation that many Oregonians, particularly at the low end, are have really no tax liability, and that is by design from the Finance and Revenue Committee, through the combination of both the where the personal income tax phases in, as well as the effect of the credits that are offered, whether it be through the Medicare premium or through the employer payroll tax. And so the question around ownership complements this question around the soft cap, and sort of how does one balance the burdens of paying for the plan across income while acknowledging the intent here to provide more benefits and not to burden lower income households. And so and this is some ongoing work that the group is working through, and we can talk about sort of ownership, but I think there is a sort of obvious relationship between the impact of this is to what extent do lower income households should have some positive liability for the plan, right? And I think the idea here is not about equity perhaps, but it is about sort of like, or it's not necessarily about specifically shifting the burden down, but it is what I think the idea has been trying to connect a direct link between the services and the financing structure. I won't spend too much time on this because I think, and Richard can jump in too a little bit, but Charlie, and I have had some conversations around how to structure this. And I think the simplest way to think about this would be some change to where the personal income tax starts. So what level of federal poverty level would income start getting taxed? And that you can think about the point that Mimi raised earlier about the Medicaid and not being below 140% FPL, but needing a waiver. But outside of that, one can think of it as basically, should we just have another set of marginal rates, particularly for households below 200% of federal poverty level, or slightly higher rates as that phases into higher levels of income. And so this is ongoing work that the Finance and Revenue Committee is sort of testing to understand the effect of that, with respect to how does it change this picture, but then how does it also change the effective tax rates for everyone if you have additional contributions coming from other individuals. So it's a dynamic situation. If we sort of change the ownership provisions, it will change rates, right? It will change the way we think about the household size rate readjustment factor, and as well as sort of also germane to your conversation around the soft cap. So, Richard, anything else you want to add that I might have missed in that quick summary?
No, I think I'll wait to see what questions there are.
I'll jump in quick, sorry. We talked about this already in prep for this meeting, but I sort of resist the term ownership in this context. And this board has decided that this plan is for all Oregonians and you're entitled to it based on being a resident here. And so the word ownership, I understand that in this context, what they're talking about is like a level of buy-in to the plan, right? But I don't like us using the word ownership. What we're talking about here is whether or not folks below 200% of federal poverty level should contribute monetarily to the plan. And so it's financial contributions of people below 200% of FPL is what we're talking about. And so what my question though is, I know like there's an idea of like a tiny percentage, like a 0.1 to 0.3% of income, that would, affect that lower income range. But when you say like a fixed dollar amount, that first option, how would that work? Would that happen on taxes? Like, is it like what would that look like?
I would say that there are lots of different ways to think about this. I think, I posited, think of it as basically the way you compute your tax. You could have, your tax contribution should be should be no less than like say $10 or whatever the liability is under the personal income tax, right? That could be a way you structure it. But, I would say practically and for ease and simplicity, you would just implement it as a marginal rate. And so, yeah, so I would say it was on there just as an exploration of all the ideas, but in most practical sense, we're really just talking about, adding a new marginal rate at that, those lower income AGIs.
So it's possible that people who currently pay no taxes because their income is so low, or get, I should say, 100% refund on the taxes, would have some tax liability, even tiny, it might $10, $20, something like that.
And Morgan, would you pull up your slide, share your screen and pull up slide 8 again?
Sure.
And slide 8 is the one with the red-green line, or the red-green margins between that one.
Yeah.
So the idea here is that look at even lower incomes, it's an old slide, but in general, you see that even at lower incomes, they're strongly better off. People with lower incomes are strongly better off under the United Health Plan than under status quo. And so there is room in there to have very small marginal tax rates of 0.1, 0.3%, and it still won't tip that very much. But in exchange for that, remember that no one will suffer not being able to get needed medication because there's no copay and there's no co-insurance and there's no being out of network, and they will never suffer personal or family financial bankruptcy. And so the idea is that it's a general participation, so Oregon can say nearly everybody in Oregon is participating in the universal health plan, and that's an argument that builds cohesion, I believe.
So can you explain then, like any green numbers? So like right now that top number is, I can't read it, or 1,800, I'm sorry.
Yes.
Is that 1,800? So that top number, but those folks right now, what does that mean though? Because aren't those folks in that income range, they currently qualify for Medicaid, so they've so what does it mean that they would have like an $1,800 benefit under the UHP? Because they currently pay nothing for healthcare and they are basically exempt from taxes because of their income level is so low. That's not in a refund, they wouldn't be getting that money.
Well, if they're on Medicaid, you're right. They don't have any. No premiums and no copays.
Yeah.
But slightly above that, say, I mean, 38% of the FPL, if you're an individual, that's roughly 15,000. And so 138% of that is going to be roughly 21,000. And then at that point, you're above the 138% of FPL. But if you go into the 35 to 40, then you're paying part of your insurance premium, either through the ACA or through your employer withholding. And then you have copays, drug copays and clinical copays. And that's removed under the universal health plan, so that's why it creates a favorable advantage of universal health plan versus status quo. Is because you're getting a share of the premium and you're getting into what we're called cost sharing, meaning deductibles and copays.
Yeah, so that's interesting. So yeah, I can see that. So 200% of FPL is $31,000
Right.
and your range starts at 30 to 35. So folks making below 200, which is the population that we're talking about, if you're below $30,000 a year, they would actually have to pay something that they currently pay
Right.
nothing.
Well, the healthcare personal income tax rate as proposed starts at 200% of FPL, so.
But if she changed.
Right, but
Oh, I'm
what we're
sorry.
talking about is this idea of, should that be the case? If we removed that 200% threshold and made the threshold 0 and your first dollar you'd have to pay. Currently, people that earn between $0 and $31,000 a year would be charged a tax that they currently are not being taxed.
Yes. I think so.
Yeah, I think the committee was generally looking at the 138 to 200, but and less at the 0 to 138. But
Okay, so 138 is 21,000. I have the.
Yeah, I know.
Yeah, 138 is 21,000. So between 21,000 and 30,000, they would be responsible for paying a tax that they don't have now.
yes. Again, they don't have the tax now, but they may have healthcare expenditures now.
No, because they would qualify unless they're choosing to, because they're eligible for Oregon Health Plan up to 200.
Okay.
Like, one of the things I think Charlie brought up in some of his calculations are out-of-pocket expenses. And, you know, going to the pharmacy and buying some vitamins or something that is not covered because it's not a prescription, but an over-the-counter med, are they paid for?
On Medicaid.
On
You could-
opiate?
Yeah, if I prescribe vitamins. And
But if you
Tylenol,
prescribe, but if I just decide I need something,
I don't-
I
what's your
think that
prescription
goes
for?
into this, well, I'm just saying that I think low-income people are not paying anything under Medicaid, under prescription from a doctor, whatever, there's nothing
And-
there. But if I go to buy some bag balm, or I don't know,
And
It's
that
not
would
just that,
change it.
because compounding pharmacies are not covered by
Yeah.
Medicaid.
anyway, I'm just saying that some of the calculations that Charlie did, is my understanding, have
The counter.
over-the-counter stuff that people are paying, because there's national data on that. And so some of the very low-income people may be choosing to go and buy something, Tylenol or something.
And
like
it's
that.
not just that,
Pharmacy.
because there are certain things that are excluded, so
but-
like,
yeah,
my kid on
right.
Medicaid, I pay $100 a month for a compounded.
But how would that be different? Because they still, now those folks would still be paying those costs outside of Medicaid,
Yeah.
because the UHP wouldn't cover those.
Yeah, no, I'm not arguing it. I'm
Right.
just trying to say how they came up with a number that they're, no, maybe I confused it. I'm just stop. It's complicated, and every time, I guess my biggest thing is kind of like yours, where I don't want to use that word ownership.
Yeah.
Because, as somebody else pointed out to me, they own with their bodies right now. I mean, they are, you know, so, but I also wanted to say there is a flat tax thing in Multnomah County, the arts tax, the $35 thing. So
That you can be
that's an
exempt from by
extra.
billing.
Exactly,
Yeah.
but anyway, but there is a way that if we wanted to make a minimal something, that it wouldn't have to be, you know, but that would be a whole nother deal and more expensive to just elect.
Okay. Metro is first, Mike Curry.
Uh,
Go ahead.
Go ahead.
I mean, I just wanted to clarify, so folks that are like on disability, on SSI, on fixed incomes as older folks, those are all below, like we're assuming they're all gonna be below the threshold.
Yeah.
Okay. I just want to clarify.
Unless we.
Well, it's based on your income right now.
Yes.
It's not based on your status in terms of disability.
Yeah.
It's based on how much household income you have. Yeah. So, yeah, so it's, disability would no longer be a qualifying thing, it's residency in Oregon that qualifies you, and then it would just be based on your income.
Yeah, I mean, it's just assuming that those are under that income threshold.
What are under that?
The scenario of somebody that's living on social security income or.
Yeah, and social security income isn't taxed in Oregon, so that's not counted.
Okay.
Yeah.
Okay, sorry, Mike, go ahead.
It's actually, it's stuff, I know figures from years ago, so I want to know now. At some point, we're gonna get to the fiscal effects of all of this and what rates, right? And we're gonna do that, I think we've got to be clear. If in fact we had some amount of contributions from 0 to 200%. There might be a trivial amount of money from people who don't make much. But now all of a sudden, you're getting more money from all 4 million Oregonians for that. And that no longer is a trivial amount. No, that's a significant amount. So what I want to know is, how many people, we do a lot of this because we're making assumptions for Medicaid, but I know there are lots of people that just don't participate in Medicaid. They tend to be younger and they don't even sign up for Medicaid. So I know we have an undercount. My question is, do we have any current information about what people's real income is from IRS compared to who's on Medicaid? Because 100% of poor people do not go into Medicaid. Does anybody know the answer to that? Because that will be another calculation ultimately we need to figure out. Am I
I
being
think
clear?
Oregon Health Authority has data on that.
Okay, all right. See, I don't know whether it's a rounding error or whether it's like $500 million.
Right.
Michelle.
Sorry, Michelle, go ahead.
Thank you, Chair. My question is around administrative cost. Has there been do we know anything about whether it would cost more? And if so, how much it would cost to collect tax from people who are not currently being taxed? Like, how much would it cost to get that $10 from that low income food insecure, housing insecure Oregonian?
I would think the marginal cost is pretty low. It all has to, I mean, it's the same tax filing apparatus. So if you're required to file a tax return, it's just part of that process. So it's just changing the computation.
Henry, go ahead. I was hoping you'd wait.
Since we have begin to discuss the overall related issue to the 3 decisions we plan to make, I want to make a more general comment for consideration as we consider not just the 3, but all the revenue options. The 2 important issues we have to keep in mind. Both important issues relate to the feasibility and viability of implementing the ultimate universal health plan. Also related to how we minimize opposition. The first one, we haven't had the budget or opportunity to do that, is we still have no idea what average or overall Oregonian think is acceptable tax rate, the additional personal health income tax. We have no idea what will break the deal, what will be acceptable. And that is very vital information before we make final decision, but we don't have information. I had talked with HCL, and perhaps HCL can help us to gauge that, because that's a vital information before we make final decision. Because we don't want to spend all the time and effort to design a very comprehensive plan. In the end, what break the deal was the tax rate, because we were so detached from what the Oregonians think is acceptable. And whatever we decide, we need to use that as a reference point, but we don't need necessary to conform to that because we also need to inform and educate Oregonians comparing with the status quo, how much they have been paying. And so they have good idea about how much in the status quo they are paying in health insurance, healthcare costs versus how much they're willing to accept for the whatever tax rate we propose. So that's a very, I think, urgent and vital information we need to get. And then the second one, again, with the spirit of minimizing oppositions, that's related to the credit, the employer payroll tax credit. The issue is for, I don't have the exact percentage, but for a large proportion of Oregonians who currently receive employer provided health insurance, historically, economists argue that has been part of their wage. So without that credit, that means for this large proportion of Oregonian, the status quo will be better because they don't have to pay health insurance, or if they have family, they only contribute to the family. But without giving them credit, then they were worse off under the universal health plan. And I know there's an equity consideration, but the overall consideration, I think for us is to weigh. There's a trade-off. How much we want to consider equity versus in the consideration of equity, how much more resistance or opposition we will encounter. So these are the general principle I suggest to consider.
And quickly respond to that. You said we have been tasked by the legislature to say, you know, how much would it cost? What would it look like to do something? So we have to submit a plan that says,
Yes.
if we're going to cover everybody at the level of benefits they've asked us to, here's what that would look like. So we will submit that. But your point is well taken that we don't know that that will be palatable. And so I think it's our obligation and our commitment to provide some alternatives to that, to give the legislature some options. But we will deliver on that, what we've been asked to do, which is to cover everybody at this level of benefits. Here's what it would take, but then have some other ideas in there as well.
One possibility to address that is, given, say, we have limited information about what Oregonian thinks palatable, we might provide at least 2 or 3 options in terms of finance, because if the personal income tax we propose become too high, we don't want that to be the deal breaker.
The deal breaker.
Then we have to devise alternative
Yes.
revenue source. So that's probably something we can consider.
Yeah, thank you. I was hoping you would weigh in on the contributions at the lowest income level. The option between having an exemption threshold at 200% of federal poverty level versus asking everyone, no matter their income, to contribute something to the plan.
My personal preference is to reference current Medicaid eligibility, current OHP. Yeah.
Oh, current.
OHP.
Which would mean continue to exempt people below
Mhm.
200%.
Yeah.
Yeah, do you want to say why?
But again, we want to minimize, again, this is a trade-off. We want to minimize opposition. We need to mobilize all the support we can get. So again, there's a trade-off. Everything we consider has a trade-off.
Yes.
And what I just made a comment is we need to consider the trade-off between mobilizing support for this universal health plan versus equity. And that's the trade-off between the two.
Okay. Amy, last comment, and then we got to.
Oh, and Michelle has her hand up.
Oh, okay. Go ahead.
My comment was just, I recall very early on, there was conversation about creation of some kind of public facing calculator.
Yeah, that's in the works.
Okay.
Well, we need to make some decisions.
Yes,
So the
I just
purpose
wanted to, yeah, if you
Right.
can connect this conversation with.
Absolutely. The
that.
point of making some decisions today is so we can build that calculator.
Okay.
So we got to make some decisions. So
Okay.
we're going to move
Because
on.
that's what's gonna
You're
help
in
us.
fun. Go ahead, Michelle.
And polling, I just want to say the word polling somewhere in the.
Yes, go ahead, Michelle.
Thank you, Chair. My thoughts are on this are that I think it would be appropriate for us to recommend to the legislature that they fund and contract with a, somebody to do some polling. I think that could be an appropriate recommendation. And I think that would, since this is going to be a government program, it might be appropriate for the state to do that. And they may have contractors in capacity if that's what they chose to do. So I think making some recommendations with our proposal in September, to me, is part of our job about what next steps are before, implementation. But I also just wanted to comment, my understanding of the logic of ownership or those, whatever word you want to call it, is really from behavioral economics. And it's applied to consumers with discretionary income. Like that's really where it comes from. So to me, it doesn't make sense to apply it to people who are food and housing insecure in Oregon. And so I just wanted to raise that concern that participation, we had a discussion at multiple points as a board around how we were not going to continue to use purely capitalist models for something that we agree and Oregonians agree is a need, a right. And so we're not going to replicate consumer models. So participation outside of a consumerist model would look like going to the doctor, improving your health, not paying $10 when you are struggling to put food on the table. So wanted to just put those out there. I feel very strongly opposed to the idea of participation in taxation for people below 200%.
Okay, thank you, Michelle. So let's try and get some decisions made. So again, 3 decisions. One, the rate of the employer payroll tax credit, which the committee has proposed should be 50%. Whether or not there's a soft cap on contributions to the universal health plan, and the committee has recommended no soft cap. And then whether or not there's an exemption threshold, that is an income level at which no healthcare personal income tax would be instituted. So we're going to have those as 3 separate issues. So I'm going to invite any board members to propose a motion on any one of those. Go ahead, Cheryl.
I feel like since we in the Finance and Revenue Committee made the motion or made the recommendation, that I should probably make a motion based on our recommendation. That makes sense.
Sounds good.
For at least 2 of the things. I just wanted to mention on the exemption threshold. I don't believe we ever voted as a committee on a recommendation. We discussed this, and I don't remember anybody on the committee saying that they wanted to propose taxing people lower than 138%
Right.
for sure. And I even remember saying specifically, I wouldn't feel comfortable below 200%. So
Okay, so
I just
there's no
wanted, I
recommendation.
just wanted to note, there's no recommendation on taxing everybody.
Okay, okay, thank you for that clarification. Yeah, so no
And
recommendation.
there's no formal recommendation, period, but for the purpose of, our decisions today, we could make that motion to tax people above 200%. So I'm just putting that out there, but the Finance and Revenue Committee did make a recommendation on no soft cap. So that would be my first motion.
Why don't you go ahead? The motion is,
We move forward with the revenue plan with no soft cap.
is there a second?
Second.
Any discussion? Go ahead, Mike.
I don't have a conclusion with this as much
You
as
guys speak up, Mike.
I think I would be influenced about whether there was a soft cap or not based on what the basic rate is. And, candidly, in my mind, not being a member of the Finance Committee, I think with hearing the numbers of 8 or 10% income stuff, going over
Right.
his things, I mean, some of this doesn't make a lot of sense to me. What doesn't make sense to me is if we're concluding that we're gonna sell a increase in the Oregon income tax of 8, 9, or 10%. I mean, that to me is an unreality. I think we need to spend a lot of time figuring out how do we get the overall need down. And then I think we can easily say, if the overall, I'm gonna throw out numbers and anybody please critique these. But if it's overall 10% versus 4%, those are two different worlds, and then 4%. I would have
Right.
no problem with.
What we've seen so far, Mike,
Right.
though, is that the differences aren't gonna be that big.
Right.
Right, so basically what we're voting on with the soft cap is the concept, the idea that at the highest income levels, there should be a limit of the liability of the higher income earners to contribute to the soft plan. But you're right, I mean, it all feeds in, but knowing what that ultimate rate's gonna be is gonna depend if there's a soft cap or not, because if there's no.
Right.
Right, so they're all kind of depend, so what we're voting on is a concept, and then, right, and just that idea that should we use that soft cap to sort of balance out the contribution of those higher income earners, right?
Okay,
Yeah, okay.
that helps me because, again, we can do these vote. What makes me nervous here is to make these vote things, and if anybody ever brings up an item again, it's like, well, we made that decision stuff, right? I mean, I think it'd be very good if we made a whole bunch of decisions today, but recognize that after we, go public with stuff.
Yeah.
We should have the ability to learn
Absolutely,
and make this iteration.
These are proposals.
Yeah, these are just proposals. That's a
Okay.
great reminder, Mike. I appreciate you bringing that up because we need to make some decisions so that we get some final structure to the revenue
Yeah.
plan. Then next month, we're gonna be talking about the expenditures and there's gonna be a whole set of other issues there. And then we're gonna spend a few months as a board trying to reconcile all that information. And you're right, we have the ability and the right to change what we're deciding here. We just need to make our initial best decision so that we can put some models together. And then we'll see how things sort of sort out and we might have to adjust as we go down the
Right,
line.
thank
But we want to have enough time to do that and
Thank you.
yeah.
Judy has her hand up.
Judy, go ahead.
Thank you, Chair. I have a couple of concerns about no soft cap. One being folks who are most impacted by no soft cap are most they have the most ability to leave the state and get out of the system. And my second concern is that middle range income, which is kind of like the professional earners income range, are folks who have mortgages and academic loans. I'm thinking clearly specifically of new physicians, but there are also folks who can make a choice to live and work and contribute in the state or not. So I have concerns about no soft cap.
Go ahead, Michelle.
Thank you, Chair. I hear that, and I think this is a tough, one of many tough decisions we're going to have to make, with the caveat that it is pending public engagement and feedback and not final. But I do just want to note again that we're talking about like 0.7% that would be subject to that highest rate, and I think it's my understanding, if I followed appropriately the slides and the discussion today, is that if we include a soft cap, the percentage for those middle groups would be higher than the percentage for that 0.7%. And I think going to Oregonians, going to voters and saying, here's our plan, people at the lowest end pay nothing, people at the highest end pay a lower rate, and you in the middle pay the most, is a non-starter. And I think it's out of line with our values, and I think it's not going to be an easy sell to Oregon voters and really easy to run against. So that is my concern, and why I'm in support of a soft cap, or of no soft cap, sorry.
Thanks, Michelle. That's an interesting way of framing it. And that's exactly, I think, what you're open and add.
That decision.
And that's exactly what the Finance and Revenue Committee
That's right.
has said.
Yeah.
And so that's what I'm for no soft cap. Because it is a relatively small group of people, and yes, and many of the studies show that oftentimes it's not younger people. There are a few younger big earners, they may move. But most other people do not move because of taxes. They make noise, they talk about it, they may influence and whatever. But honest to God, they don't pick up. They stay where they are. And if you look at this latest data about Oregon, we're the #1 state for people moving in. For whatever reason.
Crisis.
So anyway.
Okay, thanks, John Wick.
I have a quick clarifying question. Have we already decided how we are going to tax household member?
No.
If not, this will be an important consideration related to all the tax. Let me just give you an example. In Taiwan, the universal healthcare is largely based on payroll tax. and payroll tax split between employer and employee. But then each household will be designated one person who is working as the primary subscriber, and then those who are not working will be the household member. And so the way Taiwan tax them is for each non-working household member, you simply multiply by whatever tax rate that primary person. So if you have additional 3 non-working household member, then the total tax rate will be whatever that person's tax rate multiplied by 4, because you have the worker plus 3. But then they cap at 4 non-working household member, meaning the 5th and more household, they are not taxed. So this will be an important consideration. The reason I raised this is originally it was based on payroll tax alone, but then the equity consideration, they added supplemental tax that's largely related to capital gain and interest investment income. But then for that part of tax, they reduce the liability of household member to 3. For the payroll tax, it's 4, but for additional capital gain and interest, 3. So these are examples that down the road we need to consider because it affects all those taxes.
Yeah, it's a great point too, that all this can be modified in the future as well, like as we see how it all sorts out. But yeah, so we just need to get a starting point to build some models.
And I just wanted to make a point, Joey, I don't know if you had the opportunity, because this has come up relatively recently, if you were including in your discussion, the household size rate readjustment, which is actually built into this. So that is actually being considered. I'm going to turn it over to Richard if you want to explain it a little bit.
That's correct.
Okay, more concisely than I can. So there is a consideration after 260% of federal poverty level,
Up to 520%.
up to 520%, there is per each additional household member, each additional exemption, I believe is how it's worked out. There's additional monies paid. So I'm not
But
explaining.
we
that
haven't
completely.
decided how much that would be.
He's just saying, Chenwei's making the point that it's hard to decide on soft cap until we've decided the other parts of the tax, and which is true, that was Mike's point as well, but the idea is just voting on this concept of should there be a soft cap, but yes, they all influence each other. We just need a starting point so that we can build some models, and then we have the potential to revise it. Okay, so there's been a motion for no soft cap, it's been seconded, is there any further discussion? Okay, let's do a roll call vote for whether or not you agree with no soft cap.
Helen Belanca,
Yes.
Chun-Wei Chi,
Yes.
Amy Fellows,
Yes.
Michelle Glass,
Yes.
Bruce Goldberg is on leave, Judy Richardson,
Yes.
Cheryl Ramirez.
Yes.
Mary Lou Henrich,
Yes.
Mike Leahy.
Oh, yeah.
That passes. Thank you.
Great, thank you. Okay, so there are 2 more decisions. We have a little bit more time. So there's the exemption threshold income level, and then there's the employer payroll tax credit amount, which the committee has proposed 50%. So I invite any board members to make a motion on either of those issues.
I'll make a motion on the employer tax credit rate at 50%, which was the Finance and Revenue Committee recommendation.
Great, is there a second?
Second.
Any discussion? Okay, I don't see any. I'll do a roll call vote.
Helen Belanca,
Yes.
Chun-Wei Chi,
Yes.
Amy Fellows.
Yes.
Michelle Glass,
Yes.
Bruce Goldberg is on leave, Judy Richardson,
Yes.
Cheryl Ramirez.
Yes.
Mary Lou Henrich.
Yes.
Mike Leahy.
Yes.
Thanks, that passes.
Yay, thank you. That was easy.
Yeah.
Okay, there's a final issue, and again, we don't have to vote on all of these, but if anybody's interested in making a motion regarding the exemption threshold, we could entertain that.
Could I just
Yes.
ask something? Okay, so I think we could go 2 ways. We could either just vote on whether we have an exemption threshold or not. And or we could vote on whether we agree with
38 or 2.
with the taxes starting over 200%. Do you think that's like a 2-part motion?
That might be a 2-part, yeah, that's a
Okay.
good point, yeah.
Okay, Well, then I would make a motion to include an exemption threshold.
Okay, so the motion is that the healthcare personal income tax should have an exemption threshold, an income level below which it wouldn't apply.
Yes,
Okay.
that's a better.
Okay,
Thank you.
seconded by John Ramos. Okay. Any discussion on that? Go ahead, Mike.
I have a question, maybe to Richard, but anyone, of what are the pros of doing that? What are the cons?
Well, I think that's what we've been discussing at the meeting.
Yeah, and does maybe I'm the only person who doesn't know. I still don't understand what the purpose is.
The advantage of
There
having,
are so many different permutations regarding what this stuff could be. This is hard for me to imagine what is there a right answer for this or not, and
so I think similar to the cap, we're voting on a concept, and the
Okay.
concept being that should everyone contribute financially to a universal health plan regardless of their income level? Should that be just something that no matter how much money you make or don't make, regardless, that everybody should contribute something? That's the concept versus this idea that, well, we recognize that there are some people whose income is so low that they should be exempt from paying anything at all. So it's a conceptual vote about what you believe is the right option for a universal health plan, if everyone should contribute or if we should exempt some folks.
And I just want to add what Morgan said, which made it clear to me, is the soft cap discussion was really adjusting at the top. And this discussion is adjusting at or near the bottom.
yeah.
Michelle, go ahead, Michelle.
Thank you, Chair. I would just, my comments are brief, but just pointing out that I think I have my own little printed copy of our overarching principles. And I think that this that having an exemption threshold is aligned with health equity, which we agreed was our top principle that should guide our decision-making, and minimizing financial hardship for individuals and families. I think it's also aligned with that. And so I will be a yes on this, partially for those reasons.
I agree totally with Michelle on this. I think we've discussed it at the Finance and Revenue Committee a lot. And one of my questions, I'm definitely in favor of the vote, but one of my questions is, aren't there still a lot of people who are at those very bottom levels of income that do not file income tax? So this would require them to file income tax, where they don't have a need to for anything else. I mean, just even procedurally and all of that, it seems to me for a relatively low yield. And that over 1 million people in Oregon have been getting free care. And so to all of a sudden say, guess what, this new wonderful thing's coming in, but guess what, you're gonna pay for it now. Whether we can get a waiver or not, I still, I'm at least at 138 and probably at 200, but anyway, that's all.
Okay, so there's been a motion that there should be an income threshold, an exemption threshold for the healthcare personal income tax, and it's been seconded. Is there any further discussion? Okay, let's do a roll call vote.
Ellen Belanca,
Yes.
Chen Wei Chi,
Yes.
Amy Fellows.
Yes.
Michelle Glass,
Yes.
Bruce Goldberg's on leave, Judy Richardson,
Yes.
Cheryl Ramirez.
Yes.
Mary Lou Henrich.
Yes.
Michael Leahy.
Abstain.
Yes, because of Cheryl's explanation.
Thank you.
That's everyone. Thank you.
Okay, thank you. So we have the potential now to take up a consideration of one more motion about what that threshold should be. 138, of course, is the level for federal Medicaid qualification. Oregon has expanded Medicaid up to 200% of federal poverty level. So as Mary Lou pointed out, currently, if you're up to 200% of federal poverty level in Oregon, now that's the level at which you qualify for Medicaid and therefore have no expenditures related to healthcare. So if anybody wants to propose a threshold, now would be the time to do it. Go ahead, Cheryl.
I'd like to make a motion that the threshold is 200% federal poverty level.
A second.
Amy seconds. Is there any discussion?
I'm torn between 138 and 200 because right now they're covered for free. Will they be this time next year? With all that's going on? I definitely have always fought my life for low income people, so I don't even, I'm going, really, Mary Lou? But, that idea of more people feeling they're part of this. And what level is that? I'll probably vote for 200, but I have some little misgivings here off and on, but that's all.
Yeah, so there's always an option to make a separate motion.
Yeah, I know, I know.
Counter motion that we
Yeah.
could also vote on. Yep. Michelle, go ahead.
Thank you, Chair. I would just point out that 200 to me is kind of a middle compromise number because there are a lot of parents in Oregon whose children qualify for CHIP, up to 305% of the federal poverty line, who are going to be paying more under this plan than they are currently paying. And so, I mean, 200 to me is the lowest number I would personally feel comfortable with. I think that regardless of policy changes that are happening at the national level right now, I don't think those policy changes are being guided by Oregon principles and values or by the Universal Health Plan principles and values. So I wouldn't want to align with that. But I would say at the very minimum, 200%, and just reminding the board that there are still people who are going to end up paying more, even at that level.
Thank you.
Go ahead, Mike.
Mine is just a question, and maybe the question really, thank you, Cheryl, follows that. I just want to know what the financial effect is. If it's 135, if they're 138, 200, and Michelle, that's the 300. Just how much money are we talking about? What's the difference? Because then we have, however we peg that, we then have got a responsibility to cut some expenses, right?
Right. So it's about 1 million people,
Okay,
at 1.1
But it's
something like that.
includes kids.
And if we're talking about the 200% of the poverty level is $300,000, 0.1% of that is $300.
okay.
So it's about 300 million ballpark, but probably less than that, probably between 200 and 300 million dollars.
Because how many of those are children? Like half are children.
That's true.
Yeah.
So maybe
They don't
between
pay taxes.
100 and you're right,
Yeah, it's-
100 and 150 million.
And the threshold of the people who currently don't pay taxes on top of it.
Yeah. So we're probably ballparking around 100 million, maybe less, and we're talking about a 71 to 81 billion dollar program. So
Yeah.
it's about 100 million in context of about a 80 billion.
I got the answer.
Michelle's done something.
Thank you.
Good man.
Michelle, were you gonna say something? Oh, no.
Oh, yeah, okay. Any other discussion? There's been a motion to propose an income threshold of 200% of federal poverty level. It's been seconded. Any other discussion? Okay, let's do a roll call vote.
Helen Belanca,
Yes.
Shen Wei Chi.
Yes.
Amy Fellows.
Yes.
Michelle Glass,
Yes.
Lisa's on leave, Judy Richardson,
Yes.
Ramirez.
Yes.
Mary Lou Henrich.
Yes.
Mike Leahy.
Yes.
That's everyone.
Phew.
Wow.
We did good. Thank you. Okay, we're gonna move on quickly. As all of you remember, we have extended our meeting time to 12:30. And so we have about half hour left and we're gonna go through some. Let's
do that. We're gonna skip that slide.
Skip that slide. We'll go through some committee updates and then we'll continue. This is still very much a progress discussion. But we'll continue that next month. Okay, I'm gonna turn it over to you, Judy, for an update on the operations committee.
Thanks, Chair. You know, operations has not met since our last board meeting in December. Our last meeting was December 11th. We meet again on January 22nd. For the public and any board members who are interested, there's a fabulous meeting summary that talks about our work with estimated administration and staffing costs. Thank you to Milliman for their work, designating regions and enrollment and eligibility. We'll also talk about all of those topics next week, as well as subrogation.
Great, thank you. Now to Amy and Michelle for an update
Oh,
on,
we're gonna talk, she's also gonna talk about the transition committee, and it's actually just one
Yeah.
more slide.
sorry, go ahead, Judy, I'm sorry.
That's okay. Thank you very much. So we've been working hard with the other chairs of committees to gather nominees for the transition committee group. Thank you, Lee. The focus is to create a comprehensive plan to include a timeline and steps to transition from the status quo to the universal health plan. We're looking for 7 to 11 people who have already been on committees and have been engaged in this work throughout our tenure so far, so that we can easily pick up the next steps. As you all know, this work sometimes is frenetic and fast, and we need to have input from committee members and those who are up to speed with the board's work. We proposed co-chairs. Mike, I'm requesting your assistance as co-chair, and I've offered to chair this committee, mostly as guardians and shepherds of the committee's work, with full knowledge that we will have to access multiple subject matter experts when the topics arrive. There is a charter and a work plan that was created in 2024 under the leadership of Dr. Goldberg. We're reviewing that and updating it for revisions, hopefully to help this transition committee launch from a good framework.
And so Judy, can we expect that in February, we'll see a charter and a list of committee members that we could approve by February?
Yes, Chair. Thank you.
Excellent, thank you. Community engagement communications.
Yes, so we have not met since the December board meeting. We are having a update meeting with the CAC January 28th. You all already heard the website updates. And Diana should have scheduled to meet with all the committee chairs, board members for continued planning for targeted community engagement. And yeah, I think that's our updates. Did I miss anything, Michelle? Nope.
Diana's work begins February-ish. I'm sorry, I lost track of
I
her
think
time.
that she's already scheduling appointments for the end of January.
So appointments to meet with us, but in terms of actually scheduling meetings with the targeted interest groups. March is that's March.
Yes, yeah,
Okay, great,
because meeting with you will help inform that.
great. Excellent. Anything else? Amy said no. Okay, great. So Cheryl, finance and revenue.
Very short. So first, we're having a supplementary meeting next week, next Tuesday, where we'll have Echo Northwest and Milliman both there to answer some questions and talk through, well, particularly Milliman's information, because our time got really shortened last time. And then status of Echo Northwest work. And then the February meeting, we're going to focus on the strategy for reserve funding. And I just wanted to offer Lee to talk about reserve and surplus funds. I don't know if we have time to do that, but
Yeah,
I'll
we
hand
have
it
a
over
few
to
minutes.
Lee if we do.
Sure, do we want to take the time to do this? Or-
Yes, how about how much I need?
It's like
10 minutes.
8 or 9 slides. Okay, but I can skip through pretty quickly.
Okay.
Yeah, so let's just dive right in. I was asked by board and committee members to take a look at surpluses and reserves, specifically those pertaining to coordinated care organizations as potential starting sources of funding. So just to be clear about what we're talking about, reserves refer to funds that are held by an organization to pay for their current liabilities. Surplus are amounts that are not tied to liabilities, but available for other kinds of expenses. So with respect to this question, we're really focused on surplus. Reserves, again, those are already spoken for. Next slide. CCOs, like all health plans, do have some basic surplus and reserve requirements. I won't really go into the detail due to time right there. But importantly, as they come into these contracts, they are required to come in with certain surpluses and reserves. So it's not necessarily fair to say that all of the surpluses and reserves of CCOs are something that they have acquired from Medicaid. Like any other health plan, they need to have a base to get started. Next slide, please. There are, of course, some limitations on the coordinated care organization. Specifically, we have a minimum medical loss ratio of 85% in this state. That means that of the capitation rates that CCOs receive, they must demonstrate that at least 85% of that paid for medical care of their members. So no more than 15% can be retained by the health plan to cover their administration and anything else. In the most recent year of data available, CCOs averaged 89%. So pretty good there. 89% of their capitation funds directly paid for medical expenses. A few years ago, they also, the legislature also passed this supporting health for all through reinvestment or share program, which requires that after CCOs have met certain financial standards, they do need to actually reinvest any surplus, not any, but a certain portion of surplus funds back into the community. So they do even have kind of an extra level of requiring reinvestment if they do have excess funds. Next slide. So here's the big question, which is where do surpluses go in the end? If at some point in the future, we no longer had coordinated care organizations operating in this state, what would happen with any of their existing monies? So after they had paid off all remaining liabilities. So just as any other organization, if they dissolve the first order of business, settling any outstanding debts and obligations. So settling those liabilities, leftover assets, then distributed generally based on an organization's bylaws. For nonprofits, which is most of our CCOs, this must be distributed in a manner that reflects the organization's original mission. Now, I will say that when it comes to deciding what the original mission and what use of funds reflects the original mission, they have really, really extensive discretion to make that call. So that's not necessarily something that folks will probably have a lot of success if you wanted to go in and challenge how someone was spending that unless it was really particularly egregious. I will note that though I do not have access to CCO contract language, we do have some anecdotal evidence, and from what I could find of Medicaid rules, they do not seem to have any particular other binding provisions related to surplus, which means that an organization would be able to fully use that surplus amount in whatever their discretionary, manner was, whether that is feeding it back to a parent organization that potentially also works in the healthcare space, or distributing it out to the community. The contracts with the OHA do not otherwise specify a way to use reserves. I believe that's it.
And just to clarify, this conversation came up with the idea of could we repurpose reserves from CCOs for reserves for a universal health plan? That was, or surpluses, forgive me, I'm using the wrong word. But could we somehow repurpose those if those were obligated to go back to the state? Is that, yeah, okay.
Correct.
I have two comments. One is back to one of your first slides where you said they had to be capitalized somehow. The largest plan, Care Oregon, was not done that way. It was owned by Multnomah County. It was the full, Multnomah County took the risk for 3 years before it spun out. So that particular plan I happen to know about, and it had no outside funds. All of their funds are state and federal taxes. There is no private money in Care Oregon. That's not true for all the others, but I do know that one. And the other thing is that this is the current law. It seems to me that we've got time to think about whether we want to work at a change in that and not just go, oh dear, they get to decide. So those are mine. That's a good comment.
Yeah, and living and having a child who is about to be transferred to Trillium in Lake County, that is gaining 97,000 lives as the sisters pulled out, and Trillium is a for-profit owned by a for-profit Centene out of Missouri. So that is a lot of tax dollars potentially going out of state. So I support what Mary Lou said about potentially looking at changes.
Okay, John Wayne?
This is just a quick comment. This is unrelated to the reserve for the CCO, but related to the reserve for the universal health plan. At some point, we may need to decide that. An example of Taiwan is when they make the national health insurance law, they prescribe the national insurance fund should maintain 3 months equivalent of medical expenditure as a reserve. But whenever the reserve down below 1 month, that's the time to raise tax. So something like that we need to consider.
Yeah, that's what operations is considering right now. That's where this conversation came from, is how to approach the reserve
And
situation.
what the amount is, FNR has been.
Yeah, we're gonna talk about that in February.
Okay, so moving on, was there anything else from operations? I mean, from finance and revenue?
No.
Okay, great. So plan design, has been having some really, great discussions, lately. And we are, bringing forth a proposal for a specialty care payment to this meeting. That was the bulk of our discussion last time. We also have been considering some revisions to our behavioral health proposal. We weren't ready to bring that forth as proposal, but we anticipate that's coming in February. So our focus has been on the specialty care. So the proposal is in your board packet. But the basic idea of it is that we are proposing that specialty care, which is everything other than primary care, continue a combination of both fee for service and value-based payments. Currently, fee for service accounts for about 2/3 of what specialists are paid, and value-based strategies or other alternative payment strategies account for about 1/3. So we're basically proposing that. We've had some really good discussions about the various models of value-based care, and there are some that are really high value, such as the collaborative care model for psychiatry from Washington, which we discussed, which allows a portion of salary for specialists to go towards supporting primary care clinicians in rural areas. And so that is one of the models that we thought was really worthwhile to pursue. In addition, there's another one called the bundle payments for care improvement that has shown to be very efficient and cost saving, and we propose that models like that, where we have demonstrated efficacy, demonstrated cost savings, that we could continue those. And then the other elements of the plan would be to incentivize procedures to be done in settings that make the most financial sense in terms of efficiency and effectiveness. When that can be done, sometimes facility fees are sort of a bulk of the payments. And then to prioritize uniformity and simplicity in those payment structures. We talked a bit about how specialists sometimes are paid more for similar procedures than in other countries, and that we were aware that there might be some shifts in how specialist providers, specialist clinicians are paid. And we wanted to guard against losing some core specialists from our state by thinking through some methods to create stability in that workforce. Sorry, I went through that kind of quickly. Mimi, did you want to add anything that I forgot?
No, it is. So the tenants, if you want to go, back one slide, Isabel. So again, just kind of going over the specific recommendations, and we've also definitely heard from people who, who have other considerations as well, but as it stands currently, and there is a attached the actual proposal itself, but really are there the main tenets, as Helen said, continuing fee for service, however, utilizing effective value-based payment methodologies when appropriate. Especially ones that have demonstrated financial savings while maintaining quality. Talked about the procedures, and then next slide, being performed at high value centers. The potential for using reference-based pricing to prioritize state healthcare goals. So in other words, one of the goals is to enhance primary care, being able to utilize specialty care payments and reference-based pricing in that sense. Including hospital employed clinician payments in hospital global budgets. That had actually been recommended in the hospital payment preliminary proposal, but we wanted to call out, these aren't, for example, a self-employed multi-specialty group, or perhaps a surgeon coming in, they would not be included in the hospital global budget. There's a lot of evidence that pay for performance, many of the models have not been particularly effective, and in fact have lost money. And so being just very, very critical of any kind of value-based payment model that is put forward. And then, as Helen mentioned, and this came up a lot, I would say, in the discussion at plan design and expenditure, being absolutely clear that we need to maintain a specialty care workforce. So to create a model that would not discourage specialists from remaining in the state, a small state. And again, that's another population that is relatively easy to be mobile. We want to make sure that those people are compensated in a manner that would include them being able to continue, and we have those important services for our Oregonians. And I think that's it. So next slide. Yeah, there we go. Okay, cool.
Amy, do you have a question?
Yeah, so is the assumption in this, what I believe one of our assumptions, and it's under our maximize health, that this is a place where I think maybe using the word choice is important, that the patient would have choice to go to whichever
There
provider
are
they
no
want
networks.
to.
There are no networks.
No networks and no like
There are no
kind
networks.
of prescriptive for lower income into care homes.
No, there is a role, and we talked about this at the committee, for centers of excellence, which are locations that specialize in certain procedures and have shown to provide superior outcomes. There will be sort of encouragement for people to use centers of excellence for certain high-risk procedures, but people can, there's no limitation. People go to whatever specialist they choose in the state. Yeah. Go ahead, Mike.
One, I think Mary Lou will get to this at the end of the meeting, but it's quite clear that we need to be more explicit about the fact, about affordability and about cost control. So one of the historic movements that's happened in Oregon is we spent a lot of time putting lists of things above and below the line stuff, and that's gotten kind of squishy, if you will. I'm just wondering, for things that don't really have lots of evidence that they make a difference, yet we're paying for them now. Is there any thinking about that with the specialists or not?
Yep, and we addressed that in our quality proposal of removing low value care. So that's
Okay.
already been
Okay.
approved, like thinking through low value care. Absolutely, that's a big priority.
Okay, and then the second piece is just to bring up, I think the obvious is we're not paying specialists a lot of money with the Medicaid program, but in the state, we are paying specialists for a lot of money and in commercial. And I'm just wondering at what point in time do we need to have that conversation? Because I hear us saying we don't want to lose specialists. And the other side of that is, that's kind of where the money is. And I'm just wondering what our thinking is that. And I'm not proposing we radically change anything, but I am calling the question that, that's kind of where the money is.
Yeah,
That's
especially for procedure oriented specialists.
Yes.
And so this is a place where fee for service models absolutely fall apart, because that is where the more procedures you do, the more you get paid, and there's an incentive to do as many of those procedures in as high a resource setting as possible. So that is a place where we could think through like how to make sure that all of the procedures being done are done for value-based reasons and not for quantity reasons. But ultimately, it won't be up to this board to decide how specialists get paid.
Yes.
If we do get legislation to pass a universal health plan, I am absolutely certain that the right thing to do would be to engage those specialists in those discussions and to make a decision sort of with the folks most affected. They will have a chance to weigh in on what they feel are reasonable limits on their salary, their compensation, or on how it's decided which procedures will be paid for. I know that's not for something for this board to decide, but yes, you're right. It is a place where cost containment could come into play, but it warrants a much bigger group for discussion, including those specialists themselves.
Well, I don't want to totally disagree, but if we defer that one and we keep buying the minimum assumptions, things are going to go 5% XX by the certain base, that then requires us to have an 8 or 9 or 10% rate increase. at some point, we need to have, our alternatives, something of that direction. Or we're gonna have a 7 or 8% instead of a 4 or 5% with rate increases. So
Yeah.
That's
So
my
this-
position.
This proposal is about how specialists are paid and not how much they're paid. So similar to when we talked about primary care, but you're right, there's gonna be a cost containment issue that's gonna come up, but it's just that we will use mostly fee-for-service strategies with some high value, the value-based payment strategies that have been shown to be effective. And that's the gist of this proposal, is that we want to continue that mix because it makes the most sense, but like getting down to the nitty-gritty about containing costs is part of what we're gonna have to do when the board reconciles various strategies, but also will be a multi-year discussion.
Just trying to bring it up now in January.
Yeah, no, yeah, go ahead, John.
Yeah, I'm just a short comment echoing Mike's concern. This is in a broader, bigger and long-term issues. Probably the transition committee may consider is once this past legislation in the implementation stage, we will need in the future, whatever governance entities will need at least a payment committee.
Yes.
The payment committee will then decide how and to how much we are the universal health plan are going to pay for all sectors. So that's something down the road we probably the transition committee should think about. Also echoing Mike's concern. One important mission for the universal health plan once implemented is not just simply following the trend. We also have obligation to control the costs. Yes. To get down the inflation. And there are many ways the universal health plan has advantage over all the current multiple payer, multiple fragmented systems. And we should always keep that in mind.
Yeah, exactly. We'll have a lot more leverage under this system to control those costs than we do currently. Yeah, absolutely. Great. So as chair of the Plan Design and Expenditures Committee, not as chair of the board, as chair of that committee, I'd like to propose a motion to accept the specialty care payment strategy proposal as outlined in the document. Yes, I'll make that motion.
Second.
So Michelle seconded? Yeah, go ahead, Mary.
Question, when it says preliminary proposal, as its topic.
That's how we phrase all of them as, because they're all straw proposals. Every proposal that comes to this committee is a straw proposal, meaning that ultimately the board will have some work to do to reconcile them all with each other.
Yeah.
So preliminary in the sense of, this is our best guess when we just think about this topic, when we consider this topic in the context of all of the decisions we need to make to put together a universal health plan, it might change. So that's what makes it preliminary.
Okay.
Yeah, but it's not going back to the committee. So this is the final work of the committee, and then it's up to the
Yeah.
board to kind of.
And then I also agree with Chun-Li that when we really get down to it, this committee isn't really deciding this.
Of course not.
Specific thing.
Of course not.
So.
Yeah, go ahead, Amy.
Michelle's first. Who was that? Michelle?
Oh, Michelle, okay. Michelle?
I was just gonna say, I'll be supportive of this as a starting point. I think that this is one of the pieces that'll be really valuable to ask folks about starting in March with our consultant. And one of the groups that we are mandated by the legislature to check in with are providers. So I'm looking forward to their feedback. But I think we need a starting point. And so I'm supportive of the committee's work in giving us a starting point. So thank you, committee.
Thanks, Michelle. So Amy and then Chun-Li.
Yeah, I'm generally supportive. I do have some reservations about the value-based payment, as we've heard from public comments and others. I also question how that actually works when we are no longer in networked and patient care home models. Because it seems like those things kind of go together. So how does that work?
Not always. So the collaborative care model is a great example, and one of the pieces of public comment was against value-based payment, but in support of the collaborative care model. And that is one of the ones that we also agree with, that is a version of value-based care, and it's a way of paying specialists a salary to do nothing but support rural primary care clinicians by being available for phone consultation whenever they need it and not having to see someone to get paid,
Yes.
which is the fee-for-service model.
So kind of
So
like
it's a
the Opal
version
model
of
in
value-based
psychiatry.
care that would be
Yes,
easy to
that's what
implement,
it's-
has nothing to do
So
with
it's like the
networks.
Opal model in psychiatry.
Exactly, it's like the ECHO model at OHSU is awesome, like there are ways of doing value-based care that support primary care, that support the patient, that have nothing to do with networks, and those models are really promising and effective. Yes, go ahead, John.
Just a quick comment, echo Helen's earlier comment. Whatever this board decide is not carved in stone, that they're always subject to change. And again, most of those details, except the law, is difficult to change. Even law can be changed, but most of those technical details are subject to change. And then on the value-based payment system, one cautionary note is we need to safeguard risk selection because there's an incentive for risk selection.
Yes. Right. Okay, so there's been a motion proposed to accept the specialty care payment proposal. It's been seconded. Is there any further discussion? Okay, let's do a roll call vote.
Helen Belanca,
Yes.
Shenwei Chi,
Yes,
Amy Fellows.
Yes.
Michelle Glass,
Yes.
Suzanne Lee, Judy Richardson,
Yes.
Cheryl Ramirez.
Yes.
Mary Lou Henrich,
Yes.
Michael Leahy.
Yes.
That's everyone. Thank you.
Okay, great. Yes. Is there a federal state health policy update or could we?
Should we do a time check? Because with public comment.
Yep, I got it. Yep. We're trying to get there. Is there a federal state health policy update or can that be delayed till next month?
HR one continues to be terrible.
Good update.
Okay,
Way to go, Lee.
in terms of future meeting topics, as I alluded to earlier, we spent today on revenue. We're gonna spend next month on expenditures. And then we have some hard decisions to make, but I really appreciate the board's work today in getting us closer to a revenue model. Aside from sort of digging deeper into those two major pieces, does the board have any requests for future meeting topics? Yes.
I would like to revisit a way that we could possibly have different time for our meeting that would allow more public input or people to be able to. So I just would like to revisit whether we could talk.
Do you mean the time of day?
Time of day? Like late afternoon, early evening, alternating or something that we could, because I keep getting bombarded with this question and I don't have a good answer. When they say most people cannot listen in or be part of this at 9 to 12.
Where all our meetings are recorded.
I
So,
understand that.
they're welcome to listen in
Yeah.
whatever time is convenient for them because we record every meeting and every committee meeting. So if people want to listen live, but you're welcome to propose a motion.
Would like to know if we could just even revisit that one little piece. That's all.
So that would require a motion and a decision of the whole pool.
I know.
And I'm not sure
But
that, okay.
next, you were asking for items.
Oh,
put on the
to discuss
agenda
it, to
To
discuss.
discuss it.
Okay, we'll add it to maybe to the ED report next month.
Sounds good. Yes.
Okay, we'll talk about it then
And
and
me, Mary Lou.
That's all.
bring it up. Okay. Great. Any other future meeting topics? Go ahead, John.
I already mentioned to you earlier, because when I was in Taiwan, I attended two international conference on universal healthcare.
Oh,
So I
yes.
propose
Yep.
that in February, I will make sure 20 minutes presentation to share some of those insights.
So excited.
We're looking forward to that. That's excellent. Thank you, John. Yes, so we have that.
Also, during that conference, my advisor, Bill Shell, was the keynote speaker, so I get to reconnect with him. And he was consulting our task force, so he's still very interested and concerned about our progress. So he asked me to send him all the relevant information, so I did. After I come back, I
Great.
sent him all the information related to this board.
That's great. And Mike?
Again, for future topic, I would like us to, eventually this spring be clearer that we're moving toward a public utility model. And because I just, if every topic the insurance paradigm, as someone who's been a health plan manager, we gotta get off of it, and I don't know how we do that as a board and how we do it as committees, but I sure see it, and I think it's a problem unless we address it.
Yeah, thank you, Mike. That's a great suggestion. And we have some communications experts that we could engage with that, and some global health experts in both you and Chunwei. And like, we need to start thinking about how we start framing it up as a public utility rather than an individual product. Thank you. Yeah, we should definitely include that in one of our future meetings. Any other future meeting topics? Okay, so I believe we just have one person who has signed up for public comment. Am I right, Isabel? Okay, so Colin.
We have two 1-minuters in addition.
Sorry.
And they signed up.
Okay, so I'm gonna ask in the future that all public comment you sign up by 8:50. Today is an exception because we're just implementing that rule today. But in the future, we'll have all public comment has to be signed in by 8:50, please, in the morning. Thank you to our interpreter, but your mic is on. Okay, so Colin Stackhouse, I believe, is first. Colin, if you're online, you have the floor.
Hi all, thanks. Can you hear me okay?
Yes.
Yeah. I want to start off with gratitude. I'm really grateful for the opportunity to speak. And I'm truly really grateful that there are so many providers and physicians that are on this board. I think that it's really important. It is really ironic that the content of what I need to express can only be limited to these 2 minutes, because the important message that we as Healthcare for All Oregon and myself just as a patient advocate needs to get across is that this current public engagement opportunity is not good enough. Chair Blanca and I have had a couple emails, and she's let me know that one of the best ways she perceives for the governance board to receive comments is through the form of written public testimony. But I've seen in real time how that falls incredibly short. Healthcare for All Oregon submitted public comments on behalf of 282 patients here in Oregon, 282 residents, saying to you that we are desperate to have more opportunities to speak to you. And at the beginning of this meeting at 9 o'clock, that wasn't acknowledged in the slightest. So written comments still don't actually make it to your eyes or to your ears, since there's no, proof that you guys are able to actually understand those public comments. I'd like to read the 4 main bullet points that we requested, again, as a group of almost 300 Oregonians that would love to be able to participate in these meetings. We would request that there can be at least 3, this is bare minimum, 3 governance board meetings outside of working hours, such as 6 p.m. or later on a weekday or on a weekend day, so that the public can attend. Choose at least 2 locations outside of Salem to hold a governance board meeting. You have the power to make this happen, and you're choosing to not do that. And then finally, encourage Artemis Consulting and Diana Bianco to really engage with the public and not just the legislatively prescribed groups. We want more patient input. Thank you.
Okay, thanks, Colin. And so my apologies again, there was late public comment that was added late to the website. I was working yesterday and I have to prepare for this meeting several days in advance. And so I didn't see the public comment that came in late. So I certainly will, as I always do, and I assume all the rest of the board members do, read every bit of written public comment. That piece was added late to our packet. So there's limits to that. Okay, so and then I am missing the public comment sign-up sheet. So somebody in the room said that does somebody in the room have the public comment sign-up sheet?
I was going to.
Oh,
So it's, first of all, Pamela. And then I need to read.
okay. So, okay, and I'll remind you, Mike, too, that we're gonna try and do one either before or after the meeting. And so not both, but again, we're just starting that today. So go ahead. We can give 2 minutes. Did you say one minute each to Pamela and then 1 minute more to Mike? Oh, okay.
Come on, you're up. Come over to the table.
And Pamela, if you can introduce yourself with your first and last name, I didn't quite catch that from.
Where is it best for me to?
Just right
start?
there.
Just to
Right
the
here.
owl.
Yep, you get to the owl.
That's it.
So as Colin expressed, I'm deeply grateful for you folks and the work you do. And and Michelle, whose back is to me, my back is to her. Thank you so much for pointing out the omission that in quoting the behavioral therapy research on buy-in, on ownership. That is incredibly important, and I want to speak to that for just a tiny bit. I heard that you all voted the way that I would want you to, but I want to underline something. A few years back, I was in charge of a community garden. All of these people were very low income. None of them will be paying taxes for years. I mean, they aren't going to be earning that. And this community garden was just starting up, and we were told we needed to charge something for the plot so that people would have buy-in. And I can't.
Your minute's up. Go ahead, please keep going, but,
Okay.
The minute is up.
So we'd set it at 25, we backed it down to 10. Nobody could pay that. We scholarshiped everybody in. The result was we saw what kinds of buy-in are other than dollars. The children went from 0 to 1 fresh vegetable per day to 3 to 5. There was larger community participating projects, not only in the garden, but in ESL and community events. And the garden is still going today. I just want to underline that buy-in looks very different if you have no discretionary income. And to make a middle-class virtue out of that as a hard and fast rule does everybody a disservice. We lose when we do that.
Thanks, Pamela. Go ahead, Mike.
Thanks, Chip. Just to follow up on Tenway's tech efficiency versus normative efficiency, I'd like to comment that not only should we look at the tech variance in how much people pay over the quintiles, but the pain of tax level. And if you look at that kind of chart, it will look pretty level, even the one that we have here. So that's another consideration. And also, it's not completely true that people on Medicaid don't spend money on their healthcare. And people with chronic illnesses do often have to choose between healthcare and food. And the one way I say to comment on Helen's comment, that when we have one database, outliers become apparent. So if someone's doing a heck of a lot of MRIs, we can look at that, and that happens to be an orthopedist that deals with scoliosis. And we understand that, why there's so many MRIs. But most of the time, there will be reason to look at somebody who's doing too many procedures. Thank you.
Okay, thank you, Mike. I appreciate it. And then Mary Lou had a reflection.
Okay, Mimi copied off this article from Representative and Dr. Cyrus Javidi.
Yeah.
And I encourage you to read it. I think it is really well done. When I sent it to Mimi, she went, wow, right on. So my reflection after all of this, basically saying, time is running out. We've got to control the costs. We have got to, the whole 9 yards. I think his stuff is really good. My reflection are a couple of quotes from Maya Angelou. Number 1, do the best you can until you know better. Then when you know better, do better. And I think I helped create some of these systems that are out there because we did as best we could at the time. But I think it's time to do better. And also another quote from her was, if you don't like something, change it. So I think that's what we're doing. And I say, gird our loins, and we're moving forward.
That's Mary Lou.
Can I ask, everybody that leaves this
Okay.
here in text?
And then who would pick them up? And will anyone volunteer for a reflection for next? Well, I will choose you. We will figure something out. Okay, and with that, we are adjourned. Thank you very much.
Thank you.